Rules Committee, I come to order, and thank you very much for joining us for the day. This afternoon, the Rules Committee will be considering H.R. 849, Protecting Seniors' Access to Medicare Act of 2017, and H.R. 3922, the Community Health and Medical Professionals Improve Our Nation Act of 2017. H.R. 849 repeals the provisions of the Patient Protection and Affordable Care Act that provide for the Independent Payment Advisory Board, known as IPAB. As is commonly referred to, it is an unelected, unaccountable board dedicated to cutting Medicare payments to providers if Medicare spending targets are not met. It's important to note that this board has never been put together, appointments have never been made, and they've never met. However, even though that was a part of the Affordable Care Act, we are going to discuss it today. Repeal, I believe, will help protect seniors' access to Medicare, encouraging real Medicare reforms, and I think put an end to what I viewed was a constitutionally questionable board of unelected bureaucrats empowered to make changes without feedback from Congress or the judiciary. This legislation, I think, is bipartisan, includes some 44 Democrats who are co-sponsors. The second bill under consideration today funds essential public health programs. These programs enjoy a wide bipartisan support, and I think keep the American people healthier, including some of our most vulnerable, via the state children's health insurance program. Community health centers and other important health programs and priorities are included. It would be worth saying that to delay passage of this legislation for political purposes, especially given the lack of disagreement with the underlying policy and the fact that the Senate has passed somewhat similar reforms out of the Senate Finance Committee, would be unconscionable for us not to do that now. So it's timely. In 2015, more than 8.4 million children received their health care through a CHIP program. Waiting till December to use this program as a negotiating tactic is not something that I support, and thus we are here today to put it on the table and to effectively deal with the circumstance. This legislation also includes $1 billion for Medicaid programs in Puerto Rico and the U.S. Virgin Islands to ensure patients can continue to receive access to care. and would like to thank not only both the members from the Virgin Island and Puerto Rico, but would like to thank Jennifer Gonzalez for her thoughtful articulation that I believe helped make this completely possible. This legislation uses a number of offsets to ensure children can receive the care they need, including disenrolling lottery winners from Medicaid. Now, I need to note that the gentleman, Mr. Walden, the chairman of the Energy and Commerce Committee, will be instructing us on the final decision that has been made about these offsets, and I'm sure when Chairman Walden is here, he will delineate that information that would be necessary for all members to understand. I think it's time for the House to put aside politics, to reauthorize CHIP funding and community health center funding, and I know that this is important. My hometown of Dallas, Texas, has a regular conversation with me, and they have had that for quite some time. The disability community, in addition to others, are very interested in resolution of this matter. So I look forward to getting this legislation to the House floor to ensure that the CHIP program and health care for many vulnerable children and others is taken care of. So without objection, before we move forward, I would like to welcome all 4 members to this panel. And before we move forward, I'm going to go to the ranking member, the gentleman from Florida, for any comments he'd like to make, and then come back and discuss you being here today. The gentleman's recognized.
Thank you very much, Mr. Chairman. I have no comment at this point, and welcome our witnesses and look forward to their testimony.
Judge, thank you very much. Judge, did you have anything that anyone want to give us an update about the discussion that we gave yesterday, in particular from Ms. Slaughter, about anything in New York? Or we just need to remember, and we're watching with sorrow about the facts that come out of that, but the lives that were lost. And I know you felt very strongly about that, as did Ms. Slaughter yesterday. Thank you, sir. So, without objection, I want to welcome each of you, the gentleman from Kentucky, Congressman Guthrie, who is here, the gentleman from Minnesota, Congressman Paulson, representing the Ways and Means Committee. You're representing the Energy and Commerce Committee. Thank you very much. On our first panel, we also have the gentleman from California, Congressman Thompson, and of course, Mr. Pallone, representing the Energy and Commerce Committee from the Democratic side. So without objection, anything you brought in writing will be available to our awesome stenographer. Before we go too much further, I had understood that my dear friend Mr. Thompson might be making a request to be on both panels, or that you have to leave early, but I want to get the answer straight. Mike, any request for the committee?
Thank you, Mr. Chairman. I am going to go down to the floor and make comments on the fire bill. As you know, my district has experienced pretty devastating fire, so I'm hoping to be able to move swiftly from here down to that.
So I will acknowledge that, and at any time, I'm not sticking to that, Alcee or any other member of the committee. We do recognize that Mike Thompson would need to leave and would not hold that against him in any testimony he gives. Hope Jan's watching.
She's working. One of us has to make some money, Mr. Chairman.
Tell her I said hi. I need to also say that I've got 2 constituents who are here who have a view of the Capitol today, Robin and Lisa Stow. And I want to thank both of you for taking time. They're from Irving, Texas, and I appreciate them taking time. And our great intern, Joe, is helping them along. So, Robin and Lisa, anytime you need to leave to go on the rest of your tour, thank you. I appreciate you taking time to come see your second favorite congressman. We're now going to move to the testimony. The gentleman from Minnesota, the gentleman from Ways and Means is recognized.
Well, thank you, Mr. Chairman and members, for allowing me to testify today on the Protecting Seniors Access to Medicare Act. It's authored by Representatives Phil Rowe and Raul Ruiz, who are both doctors themselves. This bill will repeal, as you mentioned, Mr. Chairman, at the outset, the Independent Payment Advisory Board, or IPAB, that was created in the ACA, or Obamacare. As you know, the House has already voted in previous Congresses to repeal the IPAB as well with bipartisan support, significant bipartisan support. In fact, the bill, as you mentioned, also has 44 Democratic co-authors that were in front of us today, as well as receiving bipartisan support in the Ways and Means Committee markup that we had last month as well. And we all know that one of our main priorities in healthcare is to help empower parents and families and providers, and we want to give the American people and not Washington more control over their healthcare decisions. But IPAB would allow unelected, unaccountable bureaucrats, 15 of them, to have significant unilateral powers, to have the ability to push forward sweeping Medicare cuts just to keep programming spending at some arbitrary level, put them in control of Medicare, authorizing them to unilaterally slash payments to thousands of providers, which would hurt seniors, all without any accountability or judicial review or transparency. And Mr. Chairman, there are over 700 different bipartisan groups that are representing patients and providers, employers, hospitals, doctors, and other healthcare professionals that are supportive of the IPAB repeal. It's very evident that Republicans and Democrats both agree that allowing a panel of these unelected bureaucrats here in Washington to make these kinds of critical healthcare decisions instead of patients and their doctors is not the right way to keep our promises to American seniors. So I would just say that repealing IPAB is crucial to maintaining and expanding access to high-quality care for our nation's seniors. And I want to thank and call out Dr. Rowe and Dr. Ruiz once again for their leadership in authoring the Protecting Seniors Access to Medicare Act, and thank the Rules Committee for your consideration of this important legislation.
Thank you very much. Your component here, Mike, you sit on Ways and Means. Gentleman's recognized.
Thank you, Mr. Chairman, and thanks for the opportunity to testify today on this IPAB bill. First, I just want to point out that the ACA's health reforms have been a remarkable success for seniors. Closing the prescription drug donut hole saved over 400,000 Californians over $400 million on drugs in 2015. That was an average of $1,044 per beneficiary. In 2015 alone, 39 million seniors have taken advantage of the new Medicare benefit that provides coverage of key preventive services with no copayment and no deductible. It's also been successful in bending the health care cost curve. Costs across the health care system have been growing at the slowest rate in over 50 years, and that applies to Medicare as well. And due to slower cost growth, Medicare spent $473 billion less from 2009 through 2014 than it would have if pre-ACA spending trends had continued. Because Medicare isn't seeing unsustainable cost increases, in other words, because the law is working, IPAB hasn't been triggered. That's good news because it means we haven't faced any payment cuts from the IPAB. Nonetheless, I am no fan of IPAB. I've been pretty outspoken about this from the absolute beginning. I don't believe we should be deferring our authority to legislate changes in Medicare spending to an unelected board. I came to Congress and believe that all of us in Congress should be working on these issues. Congress should determine Medicare payment policies. And I'm assuming my colleagues on both sides of the aisle in Ways and Means, I worked really hard to get on that committee. And I didn't work really hard in order to pass on my responsibilities to an unelected group. But I also believe that we have a responsibility to be good stewards of taxpayer dollars. And the bill that we're considering today will increase the deficit by $17.5 billion. So I can't, in good conscience, support such reckless fiscal policy, even if I support the underlying health policy. I also share many of my colleagues' bewilderment that this bill doesn't need to be offset, whereas the legislation that we're going to consider on Friday to provide low-income kids with health services must be paid for on the backs of critical public health programs. As I said when IPAB repeal was considered by the Ways and Means Committee, I welcome the opportunity to work with my Republican friends to repeal the program, but at the same time to offset any cost with bipartisan agreements that don't hurt kids or seniors. This bill doesn't meet those requirements. Thank you, Mr. Chairman.
Mr. Thompson, thank you very much. Ms. Guthrie, we're delighted that you're here. You don't come up here often enough.
Thanks. Good to be here.
Well, I'm glad you're here. I hope you do well enough to come back.
Thank you. I hope so, too.
Jones recognized.
Thank you, Mr. Chairman. Mr. Hastings, appreciate you have the opportunity for you to be here. Medicare is crucial for our nation's seniors to see their doctors, and the program's viability must be protected. I'm proud of the bipartisan work the Energy and Commerce Committee has done to shore up and improve Medicare. But current cost projections are unsustainable, setting up financial shortfalls. There is no question Medicare must be modernized in order to continue for future generations. However, I believe that IPAB, the Independent Payment Advisory Board, is not the right approach, and a bipartisan group of my colleagues agree that IPAB is not the answer to fixing Medicare's issues. As you know, IPAB was created in the Affordable Care Act to reduce the per capita rate of growth of Medicare spending. If a spending target exceeded cuts, if a spending target is exceeded, cuts must be made. The Secretary of HHS is directed to implement the proposals made by this 15-person board automatically unless Congress affirmatively acts to alter the proposals or to discontinue automatic implementation of the proposals. This board has not yet been formed, but in such cases, the statute requires the Secretary to come up with required reductions instead. IPAB uses a spending target for triggering cuts, not consideration of quality or access, and it's true that IPAB is severely restricted in areas which it can't address costs. It can't raise revenues, it can't change eligibility requirements, it can't adjust benefits or increase premiums or copays. So what is the problem then? If IPAB can't make adjustments in any other areas, only one place is left: provider reimbursements. According to an American Medical Association survey, current reimbursement rates have already led to 17% of all doctors, including 31% of primary care physicians, to restrict the number of Medicare patients in their practices. IPAB may not be able to directly ration care, but cutting provider reimbursements to the point that doctors can no longer see Medicare patients will result in de facto rationing. As we have learned with SGR, if you pay physicians less than it costs to see a patient, they will drop out of the program. And it's inevitable in the case with that IPAB will cut payments to physicians and other healthcare providers. I'm very concerned that across-the-board provider cuts would also ignore the significant differences between state and regional healthcare needs, especially in rural areas like my district. Geographic and demographic variances exist in our nation's healthcare system, and I am not confident at all in IPAB's ability to consider these differences carefully or to adequately account for them. IPAB will not be effective in providing real solutions for Medicare solvency. It contributes disproportionately little to the projected cost savings needed, but it does have the potential to hurt seniors' access to care. Fundamentally, is a constitutional affront to the responsibilities of the legislative branch. I urge my colleagues to support H.R. 849 to repeal the IPAB, and I hope that we will continue to be bipartisan in support of this important legislation. I yield back.
Ms. Guthrie, thank you very much. Mr. Malone, welcome to the Rules Committee. You're no stranger up here, and each time you come, it offers us not only insight, but an opportunity to hear really from a leader on the Democratic side of the ideas within the Energy and Commerce Committee, and I'm delighted that you are here and the gentleman is recognized.
Thank you, Mr. Chairman, and thank you, members of the committee. Mr. Chairman, like yourself, I actually had one statement that encompasses both IPAD, CHIP, and the community health center, so I'd like to enter that into the record if I could.
Without objection.
But then I'll talk separately about the issues in the two different panels. Although I must say, look, I do believe that there's a link here in the sense that what's happening today, both with IPAB as well as with the pay-fors for CHIP and community health centers, is that there's a real effort. I use the term sabotage or taking down or continuing the repeal, if you will, of the Affordable Care Act. And I do wish, I have to say, I do wish that rather than going after different pieces of the Affordable Care Act in a matter that I see as essentially another type of repeal, that we were working together as they are in the Senate with Lamar Alexander and Patty Murray to try to come up with ways to improve the Affordable Care Act. I know that's not the topic today, but I do feel very strongly that all three bills with these two panels really are part of an overall repeal because IPAB is part of the Affordable Care Act. And I do want to associate myself with the comments of Mike Thompson. I essentially agree with him. I'm not fond of commissions, whether it's BRAC or whatever commission, because I do think that in many ways it shirks the responsibility that we are elected to do. So I do want to associate myself with Mr. Thompson's remarks. But I also want to say that basically three things. First, the reason that I'm opposed to this IPAB repeal, first of all, is it's not paid for. It seems incredibly inappropriate, in my opinion, to say that we have to pay and offset functioning of the community health centers and the CHIP program for kids, but at the same time, the $17.5 billion cost in repealing IPAB is not offset and doesn't have to be paid for. And it just seems like, you know, that the majority party decides on a given day what they want to offset and what they don't. We've got this huge tax plan that's out there that has a $1.5 trillion price tag that increased the deficit, I guess, over 10 years. That's okay. IPAB's okay. We don't have to pay for that, but we have to pay for kids. The second thing is there's no need for this. Mr. Chairman, you said yourself that with regard to CHIP and community health centers, you know, the authorization ended the end of September. At some point, not yet, but at some point, community health centers and the CHIP program are going to run out of money, so there's a need to address that. That's not the case with IPAB. My understanding is, I think Mr. Thompson said, that it's not projected to be triggered until 2021, which is 4 years from now. So why is it that we need to address this today? Again, I think it goes back to the fact that the majority party just wants to piecemeal the repeal of the Affordable Care Act. Now, this is a measure that actually, supposedly, according to the CBO, actually does things to improve costs, right? As you said, Mr. Thompson, it bends the healthcare cost curve, right? So why are we immediately moving towards that and saying that we have to do that today when really nothing is going to happen with regard to this legislation for another 4 years? I don't really understand it. So my feeling is, again, we shouldn't be dealing with this today. It's not even really an issue at this point. It's part of the continued sabotage or repeal, if you will, of the Affordable Care Act, and I think is somewhat hypocritical. I don't like to use that term. I won't use it. I'm sorry. I take it back. It's just somewhat inappropriate for me, it seems, for the majority to be saying, oh, we don't have to offset this, but we have to offset these critical programs that we'll be dealing with in the next panel. I yield back.
Thank you very much. Gentlemen, there's much to argue about today. The facts of the case are real simple. We disagreed with IPAB when it was first initiated. I understand it was part of the package. So was class. Class was part of the package. And then weeks, for sure a year after we had passed the Affordable Care Act, there was a big discussion about that. It took a couple years later, and there was an insistence to get rid of class. Class was an $80 billion pay for the Affordable Care Act that it just all disappeared because the law was already there. Well, the law is already there on IPAB, and the facts of the case, I think, are pretty simple. It's an embarrassment that somebody would come up, in my opinion, and say, well, we were there to try and keep people from effectively using Obamacare. The facts of the case, once again, are that Obamacare reimburses providers at 50% less than market. No wonder people can't go to much of a doctor. No wonder they can't find but 24 out of 100 physicians that take the Affordable Care Act. No wonder families like mine that have disabled children can't even go to children's medical centers around the country. No wonder that people who have cancer can't show up at leading-edge cancer institutes in this country and get coverage. It's a 2 or 3 or 4 tier system. What we're trying to say is we disagree with IPAB. This is an opportunity. The gentleman, Mr. Walden, made a decision to go after this issue right now. Mike, thank you. It was not convenient. It was not timely. It is simply the right thing to do. So I would say to you that marketplace should determine these things, not some unelected bureaucratic form of governance that was not even in the legislation able to be challenged by the executive branch, not be able to challenge by the United States Congress, and could not even be challenged by the court system. And I think we're doing the right thing. So, you know, we can like or not like, but I think that's closer to the truth, and that's why we're doing that. Mr. Plum.
Well, Mr. Chairman, let me just say one thing, just to set the record straight. I was one of the authors of the Class Act. I was not in favor of repeal of the Class Act. I know it was repealed, but many of us on the Democratic side.
My point is, it was $80 billion.
We're not in favor of the repeal, so I just want to make that clear. That
I don't certainly want to lump you into that. You were one of the authors who, I was here that day, March the 21st, 2009, if it were, or 8, when we passed the bill. I offer nothing but facts of the case about what happened. There are a lot of things that we've taken out that were agreed to by President Obama on a theoretically bipartisan basis that have changed. This is one of them that was never implemented, never started, and simply a bad idea. And so Chairman Walden made a determination to do it. I'm glad we're here. I don't think he's wrong, and I simply want us to know we're not taking any money from anyone. But when you do, under that circumstance, it's done to the detriment of the people I think that it was aimed to help, to keep people poor into a third or fourth tier discriminatory system, mostly people who are poor, mostly people who are disabled, is not, I don't think, the right way to do it. So I can't say we're going to do better. What I can say is we at least stand a chance. So, Mr. Woodall?
Mr. Chair, before
Yes,
you go to Mr. Woodall, if you would please, may I ask for clarification? Because
absolutely.
I'm really kind of confused here on, you're saying that hospitals don't take Obamacare.
I did not say that.
Well, what is this about people, cancer treatments being turned away?
There are
nobody
all
can
sorts
get
of
help at
cancer
the
treatment
hospital
centers in this country. There's plenty
that don't.
that do
it's
not
it's
that
regular.
do not
It's
that
insurance.
do not take
You know what I'm
that do not
saying?
take Obamacare. There are children's hospitals that do not. We could ask Chairman Burgess. Chairman Burgess has held hearings on this.
Yeah.
Only 24 out of 100 doctors take, quote, Obamacare.
That certainly seems strange to me, since the AMA and all the hospital associations and everything are worried to death it's going to be done away with.
Well,
That's so inconsistent. I frankly would like to see some evidence that people have been turned away.
Be glad to do that.
All right, cancer treatments and all that.
We have
Mr. Plum, can you?
I hate to disagree with the chairman because I don't have anything in front of me. But I mean, Obamacare in most states, certainly in my states, includes our regular Blue Cross plan.
Exactly, it's an insurance
and
plan.
I don't know. There's no hospital in the state of New Jersey that doesn't take Horizon Blue Cross, which is offered in the Obama marketplace.
What Obamacare did was really make sure that the insurance policies were worth something. And they basically took away the lifetime caps and the yearly caps, covered people with pre-existing conditions, and children could stay on until they're 26. You wouldn't go bankrupt anymore because of person, individual, paying $4,500 a year in health care. The insurance company picked up the rest of it. I mean, that's what Obamacare was. It was making sure that your health insurance policy meant something. And they said that every insurance policy has to include this. But I've not heard of anybody turning it down.
If the gentlewoman would yield, I mean, I can only talk about my state, but in my state, there are 3 health plans that are offered. 70% of the people use Horizon, which is the Blue Cross Blue Shield plan, and every hospital takes it.
They not only take it, they're happy to.
Put my signature on this, and I'll get it to you next week.
All right, I appreciate that. Thank you for yielding.
Yes, ma'am. Mr. Woodall?
Thank you, Mr. Chairman. And we don't have to wait till next week for folks to have personal stories with that. I live in one of the biggest counties in the state of Georgia. My county is larger than a congressional district. So we have lots of hospitals, lots of population, and the discounted plan that was available on the Affordable Care Act was called the Humana X plan. Well, that's what folks gravitated towards because it was the plan that folks could afford. It was the discounted plan, and not a single hospital in my home county took Humana X as coverage.
Really?
If you wanted to be covered, if you purchased the Humana X plan and you lived in Gwinnett County, you had to drive outside of the county to a different hospital. Not one hospital.
So not just Dallas,
took
Texas.
What Mr. Pallone is saying is absolutely true. If you paid more money and bought the Blue Cross Blue Shield plan that had the 80-20 split, you could use it. But what I'm saying is folks believed exactly what Ms. Slaughter believed. They believed that if only they went to the Affordable Care Act exchange, if only they bought a plan, that they would begin to have the safety and security in their health care future that they did not believe they had the day before, and that promise was not delivered on. Not in my hometown. It wasn't delivered on, and now more than a third of the country only has one plan to choose from. So when we talk about whether or not you can go anywhere you want to go, I'm glad that New Jersey has a host of different plans to choose from. Not so in the state of Georgia. Fully a third of my home state is down to only one plan left in the exchange, and it creates a lot of anxiety. I regret that we characterize this discussion as an Obamacare discussion. Of course, we put the IPAB in the Affordable Care Act language, not to do anything with Obamacare exchanges, but to come up with the pay-fors. And candidly, I'm grateful that folks cared enough about pay-fors in that day to try to do that. Right. To be candid and give credit where credit is due, we don't care as much about pay-fors today as folks cared about in passing that language in 2009. We haven't focused on the looming crisis in Medicare that has to be focused on. I don't like the solution you came up with. I don't like abdicating our responsibility to our constituency of dealing with the excesses of or inadequacies of Medicare funding, however you want to characterize it. I don't like pawning that off on a third party because we don't have the courage to make the decisions ourselves. But at least you tried to do something. And I think you get credit. I think you get credit for doing that. And I hope in repealing it today, Mr. Chairman, in saying not for the first time, but for the umpteenth time that this is not the right way to get this done, that we won't think that repealing IPAB somehow absolves us of responsibility of solving Medicare going forward. It was, I would argue, a good faith effort, an errant effort, a bad effort, not the right way to solve it, but a good faith effort to try to take a stab at controlling what are rising costs in ways that Congress had been unsuccessful at doing that before. We didn't do that in a bipartisan way, and I regret that. I hope when we come up with a solution, it will be done in a bipartisan way. But please, I always enjoy your testimony, Mr. Pallone, because you never read to us. You always talk to us. But I take great issue with describing IPAB repeal as any effort at all to undermine the Affordable Care Act. When folks think Affordable Care Act in my district, they think about only having one choice left in the exchanges and having insurance policies that don't cover their local hospital. That's the Affordable Care Act. IPAB is all Medicare all the time, nothing to do with anybody under the age of 65 who's not on Medicare, and it's only about who makes the decisions of reimbursement for care. Too often, with both sides in control, candidly, we have abdicated what is our responsibility as legislators to folks over in Article 2. For the life of me, I don't understand why we trust them more than we trust ourselves to get things done, but we have, and I hope this will be a step in turning the needle back on that. I look forward to talking about CHIP and CHCs in the next panel, but I'm grateful to you all for giving us a shot at doing this. I get call after call after call of just nonsensical outcomes in Medicare that none of us would agree with if we were able to work through those things one line item at the time, empowering a panel to make even more of those decisions about reimbursement. Well, I just can't stand it, Mr. Chairman. I'm going to tell you. My dad was in for cataract surgery the other day. Cataract surgery, and he had to take antibiotics after cataract surgery, and they said, would you like the shot or the drops? He said, well, tell me the difference. He said, well, the drops are more expensive, and you have to take them several times each day going forward. The shot is less expensive, and you only have to take it once. He said, well, that seems pretty clear to me. I'll take the shot. They came back a little while later and said, I'm sorry, Mr. Woodall, you can't have the shot. You're on Medicare. Medicare doesn't reimburse for the shot. They only reimburse for the drops. He said, well, I'm kind of forgetful. I don't want to have to take care of this, but I'm worried about my eyes. I'll just pay out of pocket for the shot. They said, no, I'm sorry. The law of the land, the United States of America, doesn't allow you to do that. because Medicare covers the more expensive drops that you have to take over the next several days, you are prohibited by law from paying out of your pocket for the shot that you know is going to take care of what you need. That's outrageous. It's not one of us would defend that as the right way to run an organization. I know what folks were trying to do when they crafted IPAB. I think we can do it ourselves. I don't think we have to abdicate that responsibility to others. So thank you for giving us that opportunity today. I yield back, Mr. Chairman.
Well, I'm learning things. It wasn't just Dallas. It was Georgia also. Yes, ma'am.
Wouldn't it be wonderful if we had IPAB and what they would do away with the thing that so plagued Mr. Woodall? I hope he's doing well. But I think that was the idea of IPAB, that they were supposed to look over what Medicare was paying for and to change it around and to keep it from getting out of hand and to control it. But if you think the most important thing that we can do in the Congress of the United States today is do away with something to which no person has been assigned, there's absolutely no one picked for it, and it's 4 years down the road, then I would want to interfere with your joy. Let joy be unconfined. You're killing something that doesn't even yet exist. But, you know, I think your idea of Obamacare and all the measure its cost, you did notice, I think, didn't you, when you tried to put that tacky bill up there? They took away almost everything and gave them the joy of being able to go across state lines or something. That America really reacted rather heavily there, everybody's town halls and in their offices, and I think it was something like 67, 68% of the people said don't do away with it.
I had to vote against Bone Bill up here.
Isn't that it, right?
I'm just saying I had to vote against Bone Bill up here.
Yeah.
So I get your...
Why would you do that?
Well, because I had to. Y'all put it up, and Judge Hastings wanted to test my theories here. There's a lot of disappointment in the world. I was disappointed.
I'm not talking about disappointment in the world. I'm talking about maybe a singular tragedy of what you're going to do to health care.
Well, but if it's meaningless, we're trying to take care of the law today.
I think what we're doing today doesn't make a lot of sense to me, except that IPAB may be something that's important to have, and you'd find that out later. But I think we might have, certainly I didn't see any urgency when it's not going to come into being for 4 more years, that we would take this kind of time up on it today.
Okay.
All right. Thank you.
Yes, ma'am. By the way, good to see you. Dr. Burgess.
Thank you, Mr. Chairman. And as it turns out, I get to talk about this a lot tomorrow, so I'll be fairly concise here, but I do feel obligated to point out, for people who haven't read Section 3403 of the Affordable Care Act, the makeup of this board. And unfortunately, I didn't bring my copy of Obamacare with me today, and I sincerely regret that because I would have read it to you chapter and verse. But if you look at the makeup of the board, I mean, they go to great pains to delineate people from think tanks, people from unions, people from every walk of life except physicians. And then physicians are like the last line of the makeup of this board that, oh yes, you should have an MD or DO on this board. But here's the catch. It can't be a practicing physician because you're not allowed to have outside remuneration. So by definition, you have a physician who is retired or not active in practice. That is not a good way for this, for the configuration of this. I'm grateful that we're doing this today, Mr. Chairman. It took me 13 years to repeal the sustainable growth rate formula. I wish it had never been enacted. This is a chance for some preventive medicine. Let's not do this. Let's not go down this way. This board is an unfortunate amalgam, and it needs to be done away with. And again, I get to talk about it a lot tomorrow, so I'll yield back.
Thank you very much. By the way, one of my favorite physicians, an ophthalmologist in Dallas, Texas, said, "Tell them in Texas the medical centers are kept out of the network, especially UT Southwestern and Children's Medical Center in Dallas, Texas." So, narrow networks. Yes. Well, one of them did, but Judge,
he had to go to the floor.
There may have been a discussion. I was asking you to understand that he had asked to come and go, and he needs to speak because...
Much I understand. I was just concerned with Mr. Paulson, whether or not he was... You did already?
He's.
Oh, okay. Thank you.
He was the first one. Yeah, you're doing great, Judge. I'd ask you to keep me on board, too. The gentleman from Massachusetts.
You know, I would just say that, you know, it's frustrating that we're having this debate, and this is the way my Republican friends choose to approach this issue. I mean, there are Democrats who have some issues with IPAB, and perhaps this would have been an opportunity to come together and to see whether or not we could find that middle ground. We all want to, you know, we don't want to abdicate our responsibilities, but at the same time, we have some serious challenges ahead in terms of cost that we need to, at some point, deal with. And I find it somewhat amusing to hear the chairman of this committee and Mr. Woodall and Mr. Burgess, you know, talk about how terrible the Affordable Care Act is when their alternative, their prescription, their solution was the bill that they voted on, the repeal and replace bill, that would have basically denied health care access to close to 1 million people in Georgia. That would have denied health care access to 2.5 million people in Texas. That would have turned Medicare into a voucher program. So, you know, look, the Affordable Care Act isn't perfect. We have been expressing our willingness to work in a bipartisan way to try to find solutions, to try to find common ground. At every step, we have been cut out of the process. You have no interest in working with us. You have blocked us. You know, and here we are. I mean, yeah, there are some tweaks that need to be done here. But this is not the way we approach it. And, you know, and again, I also find it somewhat ironic that we have to pay for the CHIP program. I mean, children's health care, we got to find an offset. But when it comes to repealing IPAD, we don't have to find an offset. I mean, I'm looking at this Congressional Budget Office estimate. It says it adds $17.5 billion to the deficit over 10 years. Maybe that's not a lot of money to my Republican friends. I do think that's a lot of money. Well, probably when you compare it to the $1.5 trillion in authorization to increase the deficit under your budget, it doesn't sound like a lot. You know, there's a way to do this right, and there's a way to do this that is wrong. And I would just say that this is the wrong way to do it, and no one's here to defend IPAB in every sense of the word, nor to say that everything in the Affordable Care Act is perfect. But, I mean, if we want to get this right, at some point, my Republican friends are going to have to open up the process and actually have a legitimate conversation, which we'll probably have to acknowledge that there are some good aspects of the Affordable Care Act. And there are a lot of people today who have access to health care that didn't have it beforehand. And there are people who today are not allowed to be discriminated against by insurance companies that before the Affordable Care Act could be discriminated against. So, you know, I don't have any questions other than the fact that, you know, I wish we weren't doing this, and I wish we were doing something more constructive and something better for the American people. Mr. Pallone?
I mean, I don't want to prolong it, but I really think, and my plea in the beginning was, it would be much preferable if we could have some bipartisan effort, as they do in the Senate, to try to address some things that could be done to improve the Affordable Care Act. And, you know, part of my concern with the bills that we're considering today is that they're going to go nowhere. I know the chairman doesn't like when I say that because he says, well, our responsibility is to pass legislation and the Senate does whatever the Senate does. But I know that, in effect, what we're doing today with all three of these bills, or all two of these bills, both CHIP and IPAB, is essentially punting until the end of the year. In other words, the Senate isn't going to take these bills up. And as a consequence, you know, it waits till the end of the year when we're doing an omnibus or something else, or a CR, or whatever we do, to actually deal with this. And I think that's unfortunate. Look, the biggest problem, one of the biggest things that needs to be addressed is the fact that, and I'm not saying it just because, you know, two members are from Texas, but I did go once to the Texas Medical Center, the Children's Center in Houston, right? And, you know, there were people lined up in the lobby. It's a beautiful place, beautiful lobby. It looks like a five-star hotel. But they were all waiting for the emergency room. And when I asked what was the problem, you know, I was told repeatedly it was because Texas did not expand Medicaid. And these were all people, for the most part, who had to go to the emergency room, couldn't see a doctor, couldn't go to a clinic because they, you know, because they didn't have Medicaid. And that's something that needs to be addressed, frankly. I mean, if it were up to me, I would mandate it, that, states have to expand Medicaid. Right. But there's so many things like that that need to be addressed, and I just think it's a shame that we're doing these partisan bouts today rather than trying to sit down and work these things out. And I try, believe me, on these bills.
And I appreciate it. I'm just arguing for a new process here. I mean, when you look at the public opinion polls, believe it or not, Congress is more unpopular than Donald Trump. And that's pretty low. And I would argue that if we want to regain the confidence of the American people, maybe we need to approach the way we do legislation, even on issues like health care, very, very differently. But I say that for what it's worth. I don't expect it will happen. I yield back my time.
Thank you very much. By the way, I'd like to add, without a objection, the list of the co-sponsors or sponsors of H.R. 849, and I've gone through and marked a number of Democratic members of Congress who have signed this saying they did work together, they came together and formed this bill today. So this is not some issue or any evidence where we didn't work together. This is working together. And would include a huge number of members.
Mr. Chairman,
yes,
I think that maybe some of those Democratic members may not vote for the ultimate bill because it's not paid for.
Well, maybe they won't.
And I think, when they sign on to that legislation, they sign on to that legislation because they had legitimate concerns about IPAB, but it thought that we would work through it in a process that would be responsible. Well, so we'll see how many of the members end up voting for it.
We began this discussion up front. The $80 billion for class, I do not believe was offset. $80 billion, this is $17 billion. The $80 billion wasn't offset because it wasn't really valid to have done it, and this proves that it was never valid, and it invalidates the point of the money that was simply used to try and get the bill done in the first place. But it doesn't mean we have to come back and fill a hole that was never created. You got the legislation. It was done. Over $100 billion, $100 billion worth of pay-fors presumptively were used in these because these were advances. This was to help pay for the Affordable Care Act. $100 billion, we're not making you pay it back. You already got the bill. So I don't think it's insincere on our part at all.
As I said, I think your prescription shows where your values lie on this issue.
Oh, they do, because it was never established.
The health care bill that you guys rammed through this House by a very narrow margin would have thrown 25 million people off.
All I'm saying is we're not trying
We don't want any part of that.
We're not trying to be picky today. We're just trying to get something done.
Well,
and I think we would have been attacked over anything we did, and what a shame. The gentleman from Alabama, Mr. Byrne.
Thank you, Mr. Chairman. I'm got confused in all this. I want to get unconfused again. I'll just ask Mr. Paulson. Mr. Paulson, did y'all work with some 40 Democrats to be co-sponsors of this piece of legislation?
Thank you, Mr. Byrne. That is correct. I mean, we could have brought some of those members along to testify in the Ways and Means Committee. I know when this came up for an issue, Mr. Pasquarello and Ms. Sanchez voted for the bill. So
have any of them indicated to you that they no longer support the bill?
Not to myself.
Have you heard of anybody them indicated that to anybody else?
No, I would expect we'll have bipartisan support on the floor as well.
Now, I wasn't here when the Affordable Care Act was passed, but what I understood before I came in here today was that IPAB was a part of the Affordable Care Act, and it was an attempt to save money out of Medicare and use that money that was saved in Medicare to pay for some of the costs of the Affordable Care Act. Is that right?
Correct.
Okay. So we're taking money out of Medicare that takes care of older people who've paid into the program to put into a program, the Affordable Care Act, where people haven't put a single penny in it. Is that what we did with IPAB and the Affordable Care Act?
You know, it's somewhat, under current law, CBO already assumed that IPAB will be saving money over a 10-year window, even though these price controls haven't yet been implemented. And so the assumption that preventing these price controls from going into effect is actually going to cost the government money is kind of backwards thinking.
Well, it may not actually work out, but the intent was that with IPAB, you would save money in Medicare and take those savings from Medicare, which is health care for people over 65 who've paid in this program because of their working years. would take money away from that program and put it in the Affordable Care Act, which is a program for people that didn't do any of that.
Correct.
Okay. Well, I can understand why you got 40 Democratic co-sponsors. I'm surprised you didn't have more, because it's just a bad idea to take money away from people in a program that takes care of older people that paid into it their entire working lives and put it into another program. I don't think the people that put that money into Medicare, I don't think they want us to take money out of that program and put it into another program. I don't think that's what they want us to do. So I appreciate the piece of legislation. I'm sorry we have some disagreement in here, but when I came in here, I thought this was a bipartisan bill, and apparently there are going to be some people on the other side going to vote against it, and that's what we're here for. But I appreciate you coming forward with the bill. I think it's a great piece of legislation. I yield back.
Thank you very much. Judge, do you wish time?
Yes, please.
Judge recognized.
I'll be brief, Mr. Chairman. I want to ask Mr. Malone. We hear a lot of rhetoric about IPAB being bad for beneficiaries because it's going to take away health care or cause rationing. I want to be clear what the statute says. Does current law allow IPAB to recommend rationing health care or raising revenues or premiums?
No, if I could go beyond just saying no, and maybe respond somewhat to Mr. Byrne. Look, the Affordable Care Act, as I think the chairman has said, we had basically $1 trillion. In other words, it was going to cost about $1 trillion, maybe a little less, and we had to pay for the whole thing. So there are all kinds of means of paying for it, right? I mean, I kind of disagree with Mr. Byrne because he's suggesting that people who have insurance through the Affordable Care Act aren't paying. Everybody's paying. They're either paying for the premium, they're paying for the copay, however they're paying. It's just that all these numbers had to add up, and you had to pay for the $1 trillion. But the idea of IPAD was to slow spending, Medicare spending. And the reason it hasn't been triggered is because that spending has been slowed without IPAD. And so that's why it hasn't been triggered and probably won't, as we said, for at least another 4 years, maybe even beyond, because that's happening on its own with the other mechanisms of the Affordable Care Act.
Right. In my recollection from the campaign is that it was Ms. Palin, Sarah Palin, who, for all intents and purposes, authored the phrase death panel, referring to IPAB. Do you think IPAB is a death panel, and does that sort of language, in your judgment, have any?
Well, I haven't heard that myself, and no one here has said it, to my knowledge. I think there was an effort to toy with some end-of-life issues during the hearings on the Affordable Care Act, but none of that was put in. No, IPAD doesn't relate to that issue at all.
All right. Let me ask either Mr. Guthrie or Mr. Paulson, why the urgency with reference to this particular matter? What I'm hearing is that it wouldn't be triggered for at least 4 years. And I thought Mr. Paulson's response to Mr. Byrne was very clear with reference to the numbers insofar as the 17 billion plus. But it seemed to me if we want to talk about imminent threats, that we should be talking about some Medicare deadlines that are coming up. And do you all agree that current laws for Medicare therapy caps or the Medicare home health rural add-on that ensures Medicare beneficiaries in rural communities, and many of us have ongoing, genuine concerns about our rural communities, and the GPCI, which ensures that rural physicians are paid fairly, all of these expire in 3 months. And yet we're here talking about something that doesn't trigger until 4 years. What's the urgency?
Well, a couple of things. One, I do think we need to deal with what you just described, and we are moving forward to deal with those. Also, CHIP needs to be dealt with, which we're dealing with today. Answer to that, one is, what's the urgency? One is, I think Ms. Slaughter said we're killing something that doesn't yet exist. And I think you get to why do you have it paid for in CHIP and why we're not having it paid for here is that even if you look at the CBO estimate, it says our estimates are, quote, one-sided bets that may or may not achieve savings. They said they have to speculate on the probabilities associated with such variation. So are we trying to repeal something that will never be triggered? And if that's the case, then the pay for in CHIP, we know we're going to spend the money in CHIP. We know we're going to spend the money in health centers, and it should be. That's what I think we're all going to agree that the underlying policy. It was just the pay fors that we were arguing against. But the question is, why do IPAP? I talked to a lot of people that you know, they make decisions not just on what's going to happen in the next 3 months. People who are going to look at, are they going to expand practice? Are they going to be in hospitals? And IPAP is something that in the provider community is very concerning to them. And I don't think the word rationing is in the statute, whatever, but if you're going to start saying we're going to pay providers less to provide, then I think that'll be the effect, I think. And so I think before it does get triggered, before it does have these negative effects, it's appropriate for us to address it.
Yeah, it's kind of interesting. I guess my final question would be for the chairman, who did offer a measure for replacing, but for a very protracted period of time, all of the discussion here in Congress was repeal of the Affordable Health Care Act. That went on like for about 5 years. And then somewhere along the line, it became repeal and replace. Listen, starting yesterday, people have 45 days to sign up to whatever remains in health care under the Affordable Health Care Act. People are very confused by all of what we've done. And I'm almost at the point personally where it would seem to me, let your repeal efforts go forward. And I wonder what you think the healthcare world is going to look like in light of the fact that you haven't really come up with anything that is going to replace the Affordable Care Act. I would have thought, you know, if you're going to take away my Pepsi-Cola, you're going to give me Coca-Cola, and Mr. Collins is probably pleased about that. We don't seem to be getting there. And I think that it's harmful overall with reference to the public. Mr. Pallone?
I just, Mr. Hastings, let me just say, this is my concern, right? In other words, one panel here on IPAB, then we're going to go to the CHIP program. In each case, you're taking a piece of the Affordable Care Act and essentially repealing it or changing it significantly. And, in this case, the effort to bend the cost curve, whether you agree with it or not, that was the idea. Mr. Woodhull said it was a valiant effort, even if he doesn't agree with it. In the case of the prevention fund, which practically disappears in the next bill that we're going to consider, which pays for all kinds of prevention things, which is the hallmark of the Affordable Care Act. And then the last thing is the grace period. In other words, we're going to move the grace period from 90 days back to 30 when we know that means 660,000 people, according to CBO, are going to lose their health insurance. So it's picking piece by piece by piece. And I know this panel has separated out IPAB, but I don't really think you can. That's for me as the observer looking at this, is saying that this is what the majority is doing, piece by piece. And the president's doing it with the outreach, cutting out the outreach fund, saying he's not going to pay the cost-sharing subsidies. You add this all up, and you got nothing left. And that's what's happening.
Yeah, and clearly that's the case. Mr. Pallone, you've been here. Mr. Paulson or Mr. Guthrie were not in a lot of the earlier on discussions. But I have said repeatedly, for all the years that I have been alive and an adult and in need of health care over the course of my lifetime. I don't know a single year that health care went down. Dr. Burgess did have the example in his own experience where he paid less. I used to ask the question, everybody whose health care went down, hold your hands up. And Dr. Burgess was the only person that demonstrably was able to show me that that occurred in his case. But for millions of people just like me, healthcare went up every year of my life. And I suspect whenever we finish doing whatever it is that we're doing, if we don't find a way to bend the curve, that we're going to leave a lot of people in the lurch. And I shudder to think what is going to happen with people in regards health circumstances, especially the most vulnerable in our society and those living in rural and underserved communities. The next measure we're going to take up, I'll bring up the issue of prevention and what impact fiscally that particular measure is going to have, and I'm sure that we'll talk about it. But I thank you, and I yield back, Mr. Chair.
Thank you very much. Did any other member wish time?
Mr. Chairman, real quick, on Mr. Hastings, I do want to point out that you raised some of the Medicare extenders and the therapy cap. Thankfully, we have come together on a bipartisan basis in committee to actually come to an agreement where we will move forward on those on a permanent solution, as well as some other extenders moving forward, which are very, very important.
Understanding that in about 3 months they expire.
Correct, right. Mm-hmm. So the good news is we've made progress, and that'll be coming forward through this committee, I would anticipate, in the next couple of months, Mr. Chairman. I do want to recognize, I think, to what Mr. Guthrie had said, the reason to pay attention to this now is that it was just last year that the actuary at CMS predicted that this year the target would be hit under the cap when IPAB would have to be triggered. But this year's trustees reported now we got a little bit more time. We have 4 years. But I think a lot of these organizations are looking for certainty. There's a reason that 700 different hospitals and patient organizations and veterans groups are saying this is the right bill to address now, is to give them predictability and certainty for preparing what's going to be there in the future.
Thank you. Thank you, Mr. Chair.
Thank you, Judge. Gentleman from state of Washington, Mr. Newhouse.
Thank you, Mr. Chairman.
Yes, sir.
You know, I hear a lot at home of people complaining about Congress, and Mr. McGovern talked about our approval rating being lower than the other end of Pennsylvania Avenue. And maybe part of the reason is that we don't recognize and talk about when we do work together on things. And I think this is a great example of when we should be, even though we have a debate here today, which is very legitimate, but what are there, over 40 Democratic co-sponsors to this bill? Member of our own committee, and I thank my friend from Florida, Mr. Hastings, for being one of those. We just had a great debate on wildfires earlier today and exchanged invitations to go to each other's districts. I think that this is a very healthy thing that we talk about these, but we should demonstrate to the American people that we can work together, and that's exactly what we're doing. And this bipartisan bill, I think, is a great example of that. I think it was universally expressed by all the members of the panel, and Mr. Thompson's gone, but Mr. Pallone as well, and Mr. Polson and Mr. Guthrie, and I think a lot of members have expressed frustration over this independent payment advisory board, the IPAB, which I hate talking in those kind of acronyms, but you know, for a lot of different reasons. It takes away the power of the purse that Congress should and constitutionally has. It takes away our ability to, from this unelected board, they take the power from us to be able to have a say over the decisions that they make, and I don't think that that's in the best interest of the American people. And so it just, I think because of that, the wrong direction that this takes us, that this isn't a necessarily a knock on the ACA. This is just bad policy that we need to address. And Mr. Pallone, you talked about there's no urgency here. Well, I just think I heard Mr. Polson say that just this last year it almost was triggered. And I understand that this coming year the chances are very good that it could be. So if that's the case, then there is some urgency. There is a need for us to take this action, I would think. And I would ask, I guess, Mr. Polson, if you would like to expound on that for the members of the committee and those that might be listening on why this is important to do sooner rather than later.
Well, and again, real quick, to date, the chief actuary has not found that spending exceeds the targets, and so we didn't have a proposal that has been triggered, but the actuary just last year predicted that the target would be hit this year, right? That would have to activate this type of unelected process. So we've got 4 years now, right, under the current process, but who knows what that prediction will, or estimation will be next year. And I think that's why 700 different organizations are saying, deal with this now, give us certainty, give us predictability, our hospitals, our doctors, our patient groups.
And over 270 members of the House and at least 44 Democratic colleagues agree with that. And so it seems to me that the urgency is there, that policy is something that is recognized universally, or at least by a lot of people, that it needs to be changed. And so I thank you for bringing the bill forward, and it's a good step that we should take, and would hope we can look forward to passing this on the floor this week. So, Mr. Chairman, I yield back.
Thank you very much. Gentleman yields back his time. The gentleman from Windsor, Colorado. No question. Gentleman does not seek time. The gentlewoman from Wyoming does not seek time. Is there any other member that would seek time with this panel? Well, didn't know if anybody wanted to ask a follow-up question. We want to make sure that we're fair. I want to thank
Mr. Chairman,
yes, sir.
Since I was my insurance cost was brought up, I do feel obligated to follow through on that. In 1996 or 1997, with the passage of the Kennedy-Kassebaum Act, every year I purchased a policy in the small group market for myself and my employees and their families. Costs were going up every year. With the passage of the Kennedy-Kassebaum Act, which unfortunately also gave us HIPAA, which is not a good thing, but it did give the ability to establish a health savings account. And I and a few other people in my practice took that option. And by buying that high deductible policy where the premium was significantly lower than the policy I bought in the small group market, I had dollars to put into a tax-deferred savings account, and over the next 20 years, it served me very well until one day I woke up and someone told me I had junk insurance and I couldn't buy it anymore, and it was taken away from me, and it's a day that I regret very much. And I yield back, Mr. Chairman.
Thank you very much. Further discussion? Mr. Pallone, evidently you're going to stick around for panel number 2.
Sticking around, I did want to say, Mr. Chairman, that I was asking Dr. Burgess about that book, because I always look forward when he brings his hearing book of the Affordable Care Act, but he didn't.
Boy, it is tagged up. It's got markers all
I didn't want him to think that I stole it either. I haven't seen it lately. Oh, you found it. You found it. There you go.
I want to thank this panel, Mr. Paulson, Mr. Guthrie. I didn't call you Ron Lewis, and I didn't do that. I know you took Mr. Lewis's place, and we missed him.
Ron Lewis, his wife just got a really good cancer.
Oh, we can pray for. Yeah, Brett, thank you very much. We appreciate it, and remembering a former colleague is always important. I want to call you Ron every time I see you, but only half the time. So, Brett, thank you very much. Good to see you. Thank you very much, gentlemen. We're not going to open up to the second panel. We're waiting for the distinguished young gentleman from Hood River, Oregon, who will show up with a big smile and prepared. Mr. Chairman, this is the second panel, and we are going to focus on H.R. 3922, Community Health and Medical Professionals Improve Our Nation Act of 2017. There's been much discussion necessarily about you, and before we go to, I would like to enter a statement of administrative policy for H.R. 849. Without objection, I'll enter that into the record. And, Mr. Chairman, anything you brought in writing will be available to our awesome stenographer, who would appreciate finishing out the contact that you make with us today. Mr. Chairman, we're delighted that you're here. That gentlewoman, Mrs. Slaughter, earlier said she couldn't wait to see Greg Walden, and there he is. So, and you're going to hear later, you missed the rhubarb pie. She may do it again in your honor at some point, but sorry.
Darn.
Gentleman's recognized.
I thank the chairman, and I thank the members of this distinguished panel. all friends, and I appreciate the opportunity to come before you today on H.R. 3922, the Championing Healthy Kids Act. We're here today paving the way to extend funding to improve health care access and outcome for millions of low-income children, medically underserved patients, and working families. H.R. 3922, the Championing Healthy Kids Act, funds a 5-year extension of the Children's Health Insurance Program known as CHIP, along with a 2-year extension of our community health centers and numerous other critically important public health programs, which I'll talk about in the course of my opening statement. Mr. Chairman, this bill will deliver quality health care and peace of mind to millions of our American citizens. The patients and the families helped by this bill are our neighbors. They are our friends. More than 8 million children, Mr. Chairman, receive CHIP-funded coverage. More than 25 million patients are served by community health centers and other important programs. Now, funding for these important programs expired on September 30th. Paired with repeated requests for delay from our colleagues on the other side of the aisle, who worked with us and we with them to try and find a bipartisan agreement which eluded us, we believe it is critical that we move forward and deliver on these important public health policies as we get these programs reauthorized. Patients can wait no longer. Patients need care. These programs need funding. Our states and the program administrators need certainty. So this 5-year funding of CHIP marks one of the longest extensions of the program since it was created 20 years ago, 5 years. The policy we're considering mirrors the bipartisan policy that has been introduced and voted out of our sister committee in the Senate, the 5-year extension of CHIP. Our bill includes more than $1 billion in new funding for the Medicaid programs of Puerto Rico and the Virgin Islands. We've worked closely with the resident delegates from those areas, and I know Ms. Gonzalez-Cullen is here. Jennifer has been terrific, especially on the Puerto Rico side, working with us. We all know the terrible devastation both of these areas and the people who have faced. This policy was designed to address funding shortfalls that were projected before both islands were ravaged by the hurricanes, and further supplementary relief will be critically important going forward in the days and months ahead as part of the recovery and restoration efforts. So we know we have more work to do, Mr. Chairman, for our fellow citizens. These funds today, though, demonstrate a spirit of solidarity and represent a solid down payment on ensuring that we help our fellow citizens who are in need. Now, in addition to community health centers, the bill also extends the funding for public health programs, such as the Special Diabetes Program, the Family-to-Family Health Information Centers Program, the Personal Responsibility Program, and the Youth Empowerment Program. These locally based, patient-centered organizations provide comprehensive care to those most in need. Mr. Chairman, in my district alone, there are 12 federally qualified health center organizations with 63 delivery sites that leverage more than $41 million in federal money to serve more than 240,000 Oregonians. These health centers are prevention and public health in action. I've seen it firsthand. I've met with many of the people involved in these health centers. They do amazing work. Often, they serve as the main provider of care for sometimes hundreds of miles in any direction. We're also extending the National Health Service Corps and the Teaching Health Center Graduate Medical Education Program. As we all know, these are very important workforce programs that help place qualified providers into some of the most underserved areas in our great country. This bill also eliminates 2 years of across-the-board cuts to Medicaid's allotments for disproportionate share hospitals. You would know those as DSH hospitals. I think we've all heard from our hospitals about these cuts. Medicaid DSH funding represents an important component of many state Medicaid programs and is particularly relied upon by many states to help provide additional resources to key safety net providers. While these 2 years of relief do not address the larger structural challenges with Medicaid DSH cuts, as scheduled under current law, they do allow Congress time to explore what budget-neutral approaches there might be to allocate existing DSH dollars on a more equitable and fair basis. And in Oregon, hospitals have told me this relief represents $6.8 million in the next 2 years that will help underserved populations get access to care. So we're putting off the cuts that were otherwise prescribed under the Affordable Care Act. Finally, to pay for funding these programs, we take a fiscally responsible approach. This bill redirects dollars from existing funding streams for prevention and public health efforts and allocates these dollars for critical public health programs that are proven cost-effective and successful at improving health outcomes. The bill also asks Medicare's wealthiest 1% of beneficiaries. Remember, these are beneficiaries who make more than $40,000 per month, Mr. Chairman, not per year, but per month, to pay a little bit more for their Medicare so that we can free up funding to help pay for low-income children on the CHIP program. So we're asking the wealthiest retirees in America to pay, it's about $135 more a month for their Medicare, which is still about 3 times cheaper than going to the private sector. It's still highly subsidized. Pay a little bit more so we can take care of these children on the CHIP program. This bill stops bad actors on the ACA exchanges who game the system in a way that harms taxpayers, and it returns that money to patients and providers for their public health priorities. The bill also allows states to save money by ensuring that high-dollar lottery winners are removed from the Medicaid program, so its limited dollars can be reprioritized for the most vulnerable. And it will also modernize outdated Medicaid payment rules to make sure Medicaid only pays when other third parties are not liable. Altogether, this bill prioritizes funding. It supports the right priorities in a way that does not add to our national credit card. This bill has been endorsed by leading healthcare organizations, such as the American Medical Association and America's Essential Hospitals, among others. These healthcare providers all know the same thing. This bill represents a strong step forward to preserve and improve access to health care for millions of Americans, Mr. Chairman. So I urge my colleagues to support this critical bill as you move it to the floor, which I hope you will do. So, Mr. Chairman, with that, I yield back the balance of my time. I'm greatly appreciative of the work you do up here and look forward to addressing any issues you may have.
Chairman Walden, thank you very much. Mr. Pallone, we're delighted that you're here. Mr. Chairman Walden, Mr. Pallone was here for the first panel, stuck around, going to be in the second panel, and we're delighted that he's not only here to represent his viewpoints also of the Democratic Party, but as a senior member of your Energy and Commerce Committee, we've seen him many times, and we welcome him one more time.
Mr. Chairman, if I might, I'd be remiss, too, if I didn't point out, I have my chairman of the Health Subcommittee here, too, the very able, capable Dr. Burgess.
Well, this was a setup. We knew what we were doing, Greg.
Yes, you do, Mr. Chairman. We're delighted with the good work that Mike does.
Yeah. Mr. Pallone, gentleman's recognized.
Thank you. Dr. Burgess, you have, it looks like more pieces of paper on that book than the last time I saw it. Okay. Let me say this, Mr. Chairman. I said that I introduced my statement that covered both panels and both bills before, so I'm going to try to, summarize this part of it now. But I do want to say that, we negotiated quite a bit, and in terms of the 5 years for CHIP to 2 years for the community health centers, that was something that we negotiated. And my hope, frankly, and I said this earlier in the first panel, was that rather than come here today and move these bills on the floor, that we could continue to negotiate. But that's not the case. But one of the reasons why I asked that that continue to be done is because I really think that by passing this bill on the floor on Thursday or Friday, whenever it is, that means that nothing's going to happen on this bill until the end of the year. And I think that's unfortunate because, as much as I don't like to criticize the Senate, they've only done one bill, which is an authorizing bill. They don't have pay-fors, and only for CHIP. They haven't done a bill for for the community health centers. So I'm convinced that, moving this to the floor this week is just going to mean that that's the end of it until the end of the year. And I think that's unfortunate. I think that we should have tried to continue to come to a bipartisan agreement rather than come here today. But we are here. My concern with the CHIP and the community health center bills is primarily with regard to the pay-fors. And again, goes back to what I said before. It's the money, for the most part, is being taken out of the Affordable Care Act. First of all, this idea of the grace period. Just so I can reiterate, the grace period right now says that if you don't pay your premium in the marketplace, right, within 90 days, then you lose your health insurance. What the majority has done in here is move that back to 30 days. Now, you might say, well, people should be responsible. They should pay their premium, timely. But the fact of the matter is many of these people are, going from, mouth to mouth or whatever the word is. And the CBO estimates that if you do that, you're going to have, various between 400 and 600. So I'll just say 500,000 people that will lose their health insurance and would have to wait till the next year to get back on the rolls. That doesn't help, in my opinion, because that means they go uninsured. And if they're uninsured, what does that mean? They go to the emergency room, you end up paying for it anyway, only you pay more because there's no prevention. So I think that's a huge mistake. And the whole idea of the Affordable Care Act was to get people insured, not have more uninsured. And that's what this would do. The second thing is the prevention fund. The prevention fund is exactly that. It's been a way over since the Affordable Care Act went into effect to pay for all kinds of prevention needs. With regard to kids, it pays for the child lead poisoning program. It pays for children's vaccinations. Beyond that, one of the things it does is to pay for state opioid prevention. We talk so much about opioids and the need to address that, and of course we have to some extent with CARA and with the 21st Century Cures. But some of that money, the CDC's budget, basically 12% of the CDC budget right now is from the prevention fund. So all these things, whether it's opioid prevention, diabetes, heart disease, stroke prevention, youth suicide, these are all the public health prevention programs. Now, I have to say, I'm hearing now, I won't say for the first time, but the first time since it was filed, that it does seem that, that the chairman has gone back to including means testing for Medicare. When the bill was filed, the amount for the prevention fund was increased, and the means testing for Medicare was not included. So he's moved it back again. So I don't want to confuse everybody too much, because this is what's been going on back and forth, and a lot of it has to do with an effort to negotiate. But right now, you still are taking, I don't know how much, because I haven't seen the latest version.
Would you just say, we're back to the committee-passed version.
Okay.
So that should.
But the bottom line is the committee-passed version takes a lot of money out of the prevention fund. So many of these programs that I talked about that are funded by CDC would not exist anymore, including programs for kids. So again, this is robbing Peter to pay Paul. What are we doing? We're taking money from the prevention fund, which is used for all these public health programs, to pay for the CHIP and the community health centers. We're taking people off their insurance because of the grace period being shortened to pay for programs. It just doesn't make any sense. And again, it's part of this overall sabotage, in my opinion, of the Affordable Care Act. Now, let me just mention a few other things. Puerto Rico. The bill, as it came out of committee, it seems like the bill now is pretty much what came out of committee. The bill as it came out of committee, which every Democrat voted against, I want you to understand, had a little less than $1 billion for Puerto Rico for Medicaid, but it still has a 55% match. What I'm told, talking to the director of the CDC, as well as to people, leaders in Puerto Rico, the mayor of Puerto Rico was at our caucus this morning, they don't have the money to pay for the match. Because whether you give them $1 million or you give them $6 or $8 million, which we have in our substitute, which I'll talk about a little later, it's not going to do any good unless it's 100%. They don't have the money to pay for the match. So that's the other criticism I have. And the third thing is with regard to the dish cuts. The cuts, as he mentioned, under this bill, cancels the Medicaid dish cuts for 2 years, but it creates a cliff. And many of you were aware of the SGR cliff, right? In other words, you pay for, you get rid of the cuts for 2 years, but then you create a greater cliff or bigger cuts down the road. And the theory is, okay, we're going to come back later and we'll deal with those bigger cuts later. But oftentimes that doesn't work, as it often did with the SGR. You had to go back every year, every 6 months, sometimes every few weeks, and correct the SGR. We shouldn't be operating that way. In other words, we shouldn't be saying, okay, we'll pay for those cuts by making it more severe down the road. So that's it. I wanted to just talk about, I do have a substitute. Well, let me say, now that he has brought back the means testing, let me just address that. In the committee bill, and now I guess in the bill that you're finally going to consider, part of the pay for was making those people who are at the very high end, the very wealthy, or at some level, I forget what the number was, that they would now have to pay 100% of the cost of their Medicare. Now, again, that may seem nice. You say rich people should pay 100% of the cost. But remember, they paid into the program. Now, if they have to pay 100%, maybe they'll opt not to take Medicare. And what does that mean? Well, because they can go do it elsewhere if they're that rich, find something else. Well, what does that mean? That means now the insurance pool loses those people. There's two negative consequences to that. First of all, it means everybody else might have to pay more, right? Or it also means, in my opinion, you may not want to hear this, you lose the political support that wealthy people give to a program. In other words, I don't want Medicare to become, I don't know what the word is, like a welfare program. The fact that everybody participates means everybody cares, and even wealthy people who oftentimes are more politically savvy and have more clout, unfortunately, support the program. You start having them drop out because they have to pay 100% of the cost, you're not going to have a viable program anymore. But I'll just add that because that was added here. Now, let me just talk a little bit about my substitute, Mr. Chairman, which I would ask you to consider. It's not a change in terms of the 2 and the 5 years, but it does change, as I said, with regard to Puerto Rico. I'll only mention 3 aspects of it. With regard to Puerto Rico, what we say is we get rid of the state match. We increase the cap to $8 billion, which is what we think they actually need because of the crisis that they face. And they won't have to pay the match, so they get the money up front, which we've done with other hurricanes in the state, so why not for Puerto Rico? With regard to the DISH, we have a 5-year delay, and it's phased. In other words, it doesn't create the cliff that the majority has in their bill. And the third thing I want to say is, how do we pay for all this? Well, we pay for it with a very simple thing, which I think is very legitimate. If you can get a $58 billion savings from the shift in the timing of payments to Medicare Advantage and Medicare Part D. Right now, unlike what we do with almost every other program, we actually pay those providers, or those insurance companies, I should say, up front 1 month in advance. So what we're saying, and this was actually recommended by Health and Human Services Inspector General, by the JO. It's done for the Federal Employee Health Benefits Program. You pay them the first of the month. You don't pay them a month in advance. You pay them at the very beginning of the month when they have to pay out their claims. You save $54 billion, and this is the way we should move, I think. Even if I wasn't using it as a pay-for, I would do it, because the fact of the matter is, why should they hold the money rather than the federal government collecting the interest? That's my view on that. So I yield back, Mr. Chairman.
Thank you very much. Mr. Walden, do you have any comments about the subject related to the substitute?
Well, I'm just learning about it, so trying to work our way through it, which is fine. I mean, that's the way the process works. I would say that on the part about Medicare, again, we're talking people who are making $40,000 a month. We know that the subsidized part of their Medicare would be about a third of the cost of going out and buying a plan off the exchange. So we don't think you're going to see leakage. I don't understand what the economic incentive would be to go pay 2/3 more for insurance you can still get, because we're only dealing with the Part B and Part D parts of Medicaid, not Part A. That would still be left as is. So we're asking $135 more a month is all we're asking them to pay than they pay today. And for that, we can save $5 billion and fund children's health insurance. The issue on their pay for, if I understand it correctly, raises pay-go violation issues in the House, and so probably would not sustain going forward. And so I think it has a set of underlying problems to it. Again, I think you heard we're fairly close on the timelines for SCHIP extension. I don't think there's a disagreement in terms of the programmatic pieces of this. We may differ a little on the DISH cuts, but overall, these are really important programs. And when you think about CDC and the 12% funding and all of that, that's true. We don't touch the prevention fund until 2019. So the appropriators in the 2018 year, they can do whatever they want. They've got time for 19, and there's always money. We didn't use the prevention fund fully for this. We found other offsets. So there's still money available in the prevention fund for wellness and health and all of that. fundamentally, on the prevention fund, it's $2 billion a year by mandatory spending. $2 billion a year comes into that fund every year. If we don't decide how it's spent as a Congress, it would default to the HHS secretary to decide. What we're saying is, when it comes to health and wellness and all the things that the Wellness Fund are for, taking care of children's health is pretty important, especially through CHIP. Our community health centers, if they're not doing wellness and prevention and all that, I'm not sure what their purpose is. And these other programs funded as a part of this mix, I think, are perfectly appropriate to be funded by the Prevention Fund, which has no specific requirements that you got to fund this program, that program, or the other. These are decisions made either by the appropriators, whom I have great and deep respect for, or by the authorizers, whom often the appropriators say, well, you ought to do your job and authorize these programs. We are doing our authorization, we're doing our job, and we're tapping into existing funds. On third-party liability, look, prior to the Affordable Care Act, most states had a requirement. You had to buy your insurance, pay for it actually within 30 or 31 days. All we're saying is we know that on the in the case of third-party liability, that this is an outdate. I've got to go to the grace periods, actually. Not that we can get into third-party liability in a moment if you want, but all but 2 states used a 30 or 31-day grace period for individual markets prior to the Affordable Care Act. What we're saying is, in effect, people get 12 months of insurance for paying for 9, and then they come right back on the system. We've had members the other side of the aisle who think shorter grace periods make sense. They may not agree with 30. They may think 60. Right now it's 90. A McKinsey report found that 1 in 5 exchange enrollees stopped payment in 2015, stopped payment, with nearly 90% of these individuals repurchasing a plan the following year. Of this group, half, 49%, enrolled in the exact same plan they stopped payment for in 2015. So what they did, they just stopped, and then they came right back on because of guarantee issue. This is something we need to tighten down a bit, and we do that, I think, in a reasonable way. Where else do you get 12 months of anything and only pay for 9? In anything else we do. And so I think otherwise all you're doing is shifting those costs to the people who pay for their insurance every month. Somebody's paying that. It doesn't go away. So we think this tightens it up and gives us the money to pay for things like special diabetes program for Indians. It lets us stop this abuse of taxpayer dollars and invest in community health centers, National Health Service Corps. Remember, these aren't funds going off into the stratosphere. They're being used for real healthcare priorities that I think we all share and need to be funded. And so with that, Mr. Chairman, I appreciate, again, the opportunity to be here and yield back.
Chairman Walden, your grasp of this and the exuberance that you reach it is amazing. I really saw that, and I knew how much fun you were having when I saw that you were going to make sure this gets reauthorized with you still being involved in 5 years now. So evidently you look forward to this kind of great public policy exercise. And I want to thank you for that. By the way, I need to tell you that your staff took time to come and brief me today. They did a great job. Chairman Cole.
Thank you. First I want to compliment the chairman because as an appropriator, this is exactly what you want to see done, and we really appreciate it. I know it's thoughtful. I'm actually encouraged by the amount of overlap and agreement between your 2 positions. I know you still have some knotty issues, but as Mr. Pallone said, it's mostly how you pay for it. You're not disagreeing about the importance of the program, the importance of community health care centers. So it seems to me these numbers, one way or the other, can be bridged. And I suspect you'll continue to negotiate with your counterparts in the Senate. But it's important to lay down a marker and have a place to start from. And I think this is a very, very good place, a very good piece of legislation. I do, Mr. Pallone, want to ask you 2 things, and you touched on some of this in your testimony. The first one is, give me once again, as quickly as you can, sort of your different ideas how you pay for it as opposed to what's in the bill, because we do need to pay for it. And second, I'm just a philosophical question, because I'll just be honest with you, one of the things I like about this is that you are taxing very high income, or you're charging them a little bit more on Medicare. It's an important program, but to me, when you're making $500,000 a year, you can pay more than somebody that's living off Social Security. And I would have thought that would actually be a place we could come together and agree, particularly in the case you've still got Medicare. I mean, to me, the great value of Medicare when you're making $500,000 a year is what I have is effectively catastrophic insurance. That, you know, I can literally pay a lot more than $135 more a month, honestly, at that level, and ought to be. You're going to use more than you paid into it in your life, no matter what your income level is right now. That's what all the actuarial tables said. So if we can't start with relatively modest increases on people of very high personal income, I mean, where are we going to go?
Well, look, let me say this. Earlier, when I started talking about IPAB, I expressed my concern, which is that I believe that we just keep seeing a series of efforts. I use the term sabotage, repeal, continue the repeal of the Affordable Care Act, right? In other words, if you get rid of IPAB, if you now say, if you reduce the prevention fund significantly, so all those programs don't, you know, aren't available anymore, if you reduce the grace period so that, you know, you get hundreds of thousands of people don't have insurance anymore, all these things take away from the Affordable Care Act, and, you know, the president is getting rid of the cost sharing subsidies. He's 80–90% of the outreach is gone. At some point, there is no ACA anymore. So I have to be honest and say that I do think that this is part of an effort on the part of your party to continue this repeal effort, because if you repeal it outright or you cut the legs from under all these things, that's essentially what you're doing. So to me, the pay-fors are very important. Look, the Senate has already said, oh, sure, we want 5 years to reauthorize a chip, but they don't have any pay-for. So, you know, they get a great headline. It's wonderful. They're all bipartisan, rah, 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 kumbaya, but they have no pay-for. So the pay-for is the heart of this. Now, don't misunderstand me. I don't think we should even have to use the pay-go rule for this. I mean, I was looking at this, and the last time we did chip as part of the reauthorization as part of MACRA, it was exempted in large part from pay-go, as was the 21st Century Cures Act. So if you want to say don't bother with it, that's fine with me. And I am being critical of all of you because you're saying we don't have to use pay-go for iPad, which is $17 billion, but you say you have to use it for this, which is for kids. So I don't want to go down that road. I think that the pay-go is sort of absurd in this circumstance. We shouldn't even be bothering with it. But assuming you have to do it, don't do it by crippling the Affordable Care Act. I was at my community health center in, I guess it was in New Brunswick a week ago. And I told them that part of the pay-go was the prevention fund, and they were like, well, what good is that? You know, we want you to pay for our program, and this is level funding, by the way. You know, we're not increasing it at all. This is level funding, which, you know, when inflation means they're going to actually have less money for community health centers. I would rather...
They'll come to my committee and ask for
exactly. So, but my point is...
We left a little behind.
My point is, they were like, well, we have all these programs. We have the child-led program. We have the kids vaccine program. We have the opioid prevention programs. You know, the whole point of the Affordable Care Act was prevention, right? Covering people so they didn't have to go to the emergency room where you end up paying more, okay? And I just think that by using these pay-fors, I'll just talk about the Affordable Care Act ones, which cuts back on prevention and cuts back on the number of people that are insured, you're basically helping cripple the Affordable Care Act. Now, as far as the means testing, separate, that wasn't part of what they filed, but now it's back in. It was in the committee bill. My problem with the means testing is this. I never wanted to go down the path of means testing because I do feel that what happens then is Medicare becomes like Medicaid. It becomes based on your income. Now, the problem with that is that you do start to lose the political support, if you will, of people that are higher income, which I think is important. But beyond that, now you're going to 100%. Now, the chairman says, well, Medicare is still a good deal, and so people that are millionaires will decide to buy it anyway rather than pay out of their pocket or find some other means. But believe me, the marketplace could very easily find something that appeals to those people if they have to pay 100% of the cost, and they may drop out. And again, that cuts back on the people paying into Medicare.
Well, you know, we'll just have to agree to disagree on that because, look, I don't agree with your position on Affordable Care Act, but I understand the logic of your position, and I think to me that's negotiable. But on Medicare, first of all, again, very few people, including the very wealthy, pay anywhere near in a lifetime what they draw out of the program. You just don't. I mean, every table says you pay in like 150 grand, draw out 358. So at some point that has to be addressed. If you can't do it here with people making $500,000 a year, I mean, I'm sorry, we're going to just collapse under the weight of our mandatory spending requirements, our entitlement programs. They are not, none of them are financing themselves. At some point, somebody's going to have to put more money into them. And if it can't be people making $500,000 a year, put more money into what's already a subsidized program, it still offers them protection, still gives them a good deal. I guarantee you, if they've got a good accountant, he would look at it and tell you, stay where you're at. For $135, are you kidding me? Yeah, certainly.
Mr. Vice Chairman, if I could add to that too, just to put another boundary around it, that's an individual making $500,000 a year. A couple making $875 a year is $73,000 a month. I think they can afford to pay another $100 or $200 a month. And by the way, the Part B and Part D that this applies to is still subsidized. Still subsidized. This does not apply to Part A, which is your hospital piece of Medicare. So they're still getting a really good deal there. And that's why when we ran the data, we don't agree with my friend's argument that people are going to flee Medicare at that rate, because it's still a third of the cost of what they'd have to pay for on an exchange plan. A third.
I agree with my friend. I can assure you any accountant would look at this and tell you this is a much cheaper health care bill. And all I would say is this to my friend. Again, I recognize there's legitimate differences here, and I actually think you guys will eventually get to the deal. Look, we all want the CHIP program to go on. We all believe in community.
We still have the
Senate.
Senate.
So we are going to find a way to get there.
Yep.
I would just hope when you come to a final deal that you keep this idea of the very wealth, which it seems to me, frankly, comports with generally the philosophy that most of my Democratic friends approach this, and they can pay more.
Yep.
They really can pay more, and they should pay more. They're getting essentially a subsidized benefit. And if we don't start addressing this, and by the way, as you know, we did it in Medicare Part D. We charge you more money if your income is higher than we do if you're living on Social Security. We just don't call it means testing. We call it income-related benefits, if I remember the phrase right. So we did that in that program. And I would just suggest to you, as we try to rationalize what I think are really important safety net programs. Look, I don't have some scheme to get rid of Medicare or some scheme to change the fundamental outline of Social Security. I just want to put them on financially sound footing. And I think this is a really important step in the right direction. So when you compromise, and as I know you two will, and your counterparts in the Senate, because we're going to fund CHIP, and we're not going to let community health care centers go under. We agree on that. We are going to find a way. Please don't throw out this principle, because this principle offers some stability longer term, and piece by piece, again, I always use Warren Buffett, Donald Trump, whoever's name you want to use, don't need the same Social Security and the same Medicare program that Ma and Pa Kettle living on Social Security do. They just don't. That's something I think most Democrats actually agree with, and Republicans actually agree with it. So we ought to not throw that particular tool out of the toolbox. And I want to commend you for using it, because it's easy to demagogue this. It's easy to, I've paid into it my whole life. And first of all, you're going to get more out of it than you ever paid into it if you happen to be in the generation that's on it right now.
That's right.
And so if we don't make those kinds of changes, then these programs do collapse down the road, and we do lose the community health care centers, and we do lose things like CHIP, which I know we all agree on in terms of giving health insurance support. So I just put that out there as you negotiate. I think that this is something surely we can that people that are very wealthy can pay a little bit more than somebody that's on Social Security for these kind of services.
Can I make two more points, Mr. Vice Chair? One is the notion that we're somehow reducing the prevention fund. $2 billion every year goes into this fund. Permanently, in perpetuity, unless we change the law. $2 billion every year. with all due respect to my friends in the Appropriations Committee, you decide how that money gets spent. And by the way, no decision's been made for 2019 on how that money gets spent, right? We still leave money in that fund, but we make a decision to say, when it comes to wellness and prevention, we think a chunk of this money should be spent on children's health insurance, special diabetes programs for Native Americans, a whole host of things, our health centers, that's a good and appropriate and reasonable use of money that is going to get spent one way or another, but there's no automatic call that it goes for any of the programs you've heard today, other than for a couple of years we think we ought to invest, use it here.
Well, thank you, Mr. Chairman, and thank you, Mr. Chairman, for being generous with time. I know Mr. Burgess knows a whole lot more about this than I have, but I just want to highlight that one principle. People that make that kind of money can pay a little bit more for safety net programs that, frankly, they are likely to draw more out of than they ever paid into, given what the rates they were paying into as they were going. And if we can't agree on that, we will never get those programs, critical programs like Medicare and Social Security, on fiscally firm footing. And I commend you for taking a step in that direction in what I think is a very good piece of legislation. Yield back, Mr.
Chairman Cole, thank you for your indulgence in the depth that you brought to that discussion. Ms. Slaughter.
Mr. Chairman, I'd like to ask unanimous consent to insert in the record a report from the Center on Budget and Policy Priorities. Their assertion is that 688,000 persons would lose insurance under the House bill.
Without objection.
Okay, and also unanimous consent to put into the record a letter from the President of the American Congress of Obstetricians and Gynecologists. His name is Haywood L. Brown, M.D., F.A.C.O.G. And his assertion is to pay for, while he, like the rest of us, really strongly believes in both the CHIP program and community health, he's concerned about the pay for from prevention. And his assertion as well is that every dollar invested in evidence-based prevention programs saves $5.60. So that every dollar we take out, $5.60 has to come from someplace else to cover that. So if I could do those two, I thank you very much.
Without
I yield back.
Thank you very much. Mr. Chairman Walden, I have, in order to, in case you're asked, I now have in the clerk give you a copy of that so that you might have an opportunity. Perhaps you've seen it, perhaps you have not, but I wanted to make sure you did that. Thank you very much. Thank you very much. Gentlewoman yields back the time. The gentleman from Louisville, Texas, Dr. Michael Burgess.
Thank you, Mr. Chairman. And again, I'm going to get a chance to talk about this a lot tomorrow. So, Mr. Walden, if I could, just on the issue of the disproportionate share hospital cuts that are there are part of current law, the Affordable Care Act. Is that correct?
I believe that to be the case, Mr. Chairman of the subcommittee. These are part of Obamacare projected cuts that we're being asked to turn off. We've done that before in a bipartisan way because of their impact on our hospitals that serve lower income people. And we're doing it here again for not 1 year but 2 years. To turn off the disproportionate share hospital cuts as required under existing law. The Affordable Care Act law would otherwise implement these cuts on our hospitals and probably reduce access to care.
And if someone were concerned that this does not solve the problem in its entirety that these hospitals might face, I think I have it on good authority at the subcommittee level, at least in Energy and Commerce, that we would continue to work on this issue. Yes. We did have a bill that was actually passed on the floor of the House earlier this year that completely eliminated this problem from everyone's life. Unfortunately, the Senate did not take it up, so we are where we are. But for anyone who's looking at this and is concerned that this is not a permanent fix for this problem, or that their state might not receive everything that it was due in this transaction, this is not the end of the story. This is merely a way to stop the hemorrhage of those dollars from those very critical safety net hospitals.
Yeah, Dr. Burgess, thank you for that question. You're exactly right. Nor is this the place we're going to solve every problem as a result of the hurricanes, nor is this the place we're going to completely fix DISH. This is about CHIP, this is about community health centers, and we're going to make sure 8.4 million children don't lose their health insurance under CHIP as a result of this bill. 8.4 million children. Let's not lose sight of what we're covering here, 8.4 million. And so I think that's really critical. And my friend from New Jersey and I did try to find some common ground. We stopped the process after subcommittee to negotiate at their request. We stopped the process after full committee to negotiate. Every step of the way before it came to the floor, we yielded to their request to negotiate. We couldn't get there. We tried. We have difference, you can see it here, in how we pay for it. But the long and the short of it, Dr. Burgess, is there are states, Minnesota first up, who are going to run out of money in their CHIP program right now in this month, and others are they're coming to us saying, we're going to have to send out notices to people saying, the CHIP program's coming to an end. We could wait no longer. That's why, despite the good faith efforts, and we've had very good faith efforts to try and get to yes, we couldn't do it. So we're going to take it to the Senate, try and get our colleagues over there to get to yes, and get this down to the president's desk so children don't lose access to their children's health insurance. Let's not lose focus here, what we're trying to accomplish. And so our community health centers have 2 years of funding. And
I appreciate you bringing that up too, because one of the criticisms that I've heard repeatedly is that we haven't turned our work in on time and we're past the September 30th date. But I would stress that the subcommittee did do its work. We had the legislative hearings. We were ready to go with this legislation in September, but it was at the request of the minority that we delayed our markup, and then we delayed bringing it to the floor at the request of the minority. And Mr. Chairman, I have an article from CQ Roll Call that I'll ask to be made part of the record that will reflect that.
Do that right now, gentlemen.
I would, if I might, I did find it kind of frustrating as chairman of the full committee who likes to get his work done on time. I'm an old radio guy. You time everything out to 60 seconds. You come to the top of the hour. You do your station ID. I'm used to finishing my work on time. I wanted to here. So on the one hand, I'd have my friends on the Democrat side ask me to stop and continue to negotiate, and others, not them, but others would then beat us up for not getting our work done on time. And so it was this yin-yang of, you're not getting it done, please don't get it done. You're not getting, and so this is where we find ourselves today. We tried in good faith on both sides in the Energy and Commerce Committee. This isn't an Energy and Commerce Committee issue. We really did work at it, but we just couldn't get it done.
Thank you, Mr. Chairman. Thanks for our witnesses, and I'll yield back.
Thank you very much. The gentleman brings up a point. You're an Eagle Scout. Are you going to leave your campsite better than the way you found it?
That's my goal, Mr. Eagle Scout Chairman.
There you go. That's what part of our mission is.
Are there other Eagle Scouts on this committee?
No, sir.
Well, that'll work.
I'm the father of 2. Thank you. Mr. McGovern.
Yeah, I want to ask unanimous consent to insert in the record a statement by Representative Cardenas in
Without
support of his
objection.
amendment. And I'm not here to defend the wealthy, but Mr. Palone, just if you could just, is it true that the very wealthy already pay a lot more for Medicare premiums?
Look, the problem that you have here,
Just a yes or no.
the very wealthy already pay a huge amount more, but that's not the problem.
Right. No, I know, but I just try to get it, on the record. Is it true that the very wealthy already pay an additional payroll tax into the Medicare Trust Fund?
Absolutely.
Right. And look, the real point here is that some of us have problems with these other pay-fors in this bill, especially the prevention fund, which provides grants to expand specialized services for individuals living with Alzheimer's disease, supports the National Diabetes Prevention Program, increases vaccine coverage among children. I go on and on and on. But this is the Rules Committee, and we're having this kind of bigger debate here. So we decide the process, and we decide how things come to the floor, and what can be made in order, what cannot be made in order. And I'll be very brief because it looks like the fix is in.
I was going to ask you to yield to me, though, when you're done.
Okay, because it looks like the fix is in. I noticed that, Mr. Walden, you requested a close rule, but asked the committee to provide for the adoption of your substitute amendment, which I expect this committee will do by self-executing it, because that's the way they handle those things. And but my colleague from Massachusetts, Mr. Kennedy, submitted an amendment to ensure that all CHIP beneficiaries have access to critical mental and behavioral health care services. You may disagree with it, but why shouldn't that be made in order? Mr. Cardenas has an amendment that I think is worthy of discussion. That should be made in order. My colleague from Tennessee, Mr. Duncan, has an amendment here, and some of them are germane, some of them require waivers, some of them don't. But you know what? You guys give yourself waivers all the time. This is the Rules Committee. We can provide those waivers. But instead of having a discussion about whether the prevention fund should be used to pay for this and whether or not members could vote yes or no on that, what we're set to consider is yet another closed rule. I mean, this Congress is going down in history as the most closed Congress ever. And I just have to tell you, I mean, I said this to the other panel, at some point, this process has to change. And there has to be more openness for members, not just on the committee of jurisdiction, but other members who have good ideas to be able to bring them to the floor. It is just frustrating, as all hell, to have to sit here and see members who have good ideas, Democrats and Republicans, some, ideas I may even disagree with, but they're thoughtful ideas, are being denied. And here we are again, bringing this bill to the floor, I expect under a closed rule that gives you, the chairman, the ability to have a self-executed provision to get your substitute in order. I think that that's just a lousy way to do business. I don't know if you have any comment.
Well, I'll leave that up to the Rules Committee to make the decision.
Well, you made the request for a closed rule.
Because I think, because I believe in the process we have at the committee level where we do the bulk of the work. We take the testimony, we hear from the witnesses, and we have expert witnesses that come before us. We had an open markup, and in fact, Mr. Kennedy offered and withdrew his amendment there. It's also in tandem with Mr. Hudson. They're both members of our committee. We offered to work with them, and we will going forward on that legislation. I might point out that on
substitute. I think it's not the bill. I mean,
I haven't seen his substitute.
You are bringing a substitute, right?
Actually, we're back to the original bill as it came out of committee, with other than some minor technical changes, nothing major.
But under your rationale, then every bill that comes to the floor should be closed.
I don't know about that. I do believe that.
If you want to defend that, that's fine.
No, I didn't say that.
But this place is ceasing to become a deliberative body, and I'm going to say, I have respect for everybody on the committee, but not everybody on the committee, has a monopoly on all good ideas. We have community health centers. We deal with the prevention fund. I see the benefits in my own district. CHIP is a very, very important program to us. And again, and whether you like these, and here's the thing: if you don't like Mr. Kennedy's idea, if you don't like Mr. Duncan's idea, or if you don't like Mr. Pallone's substitute, then vote no. Vote no.
Would the gentleman yield? Yeah, that's actually, I love having members come to our committee and make their ideas available to us through other members. We had a members' day on October 11th. We had 50 members come and present ideas on opioids because we know everybody cares about that. And I'm happy to sit down with any member anytime.
Do I have the right to go to your committee and offer an amendment and get it voted on?
You can certainly work it through a member on the committee. And you can talk to us on the floor.
Let's get real.
We're happy to do it.
The deal is that, I think thoughtful members are coming here. They're going to be testifying next to be able to have their amendments or substitute, whatever, in order. And it looks like the fix is in, that it's going to be a completely closed process. And I think that's unfortunate. Mr. Pallone?
I just want to say this. Maybe the fix is in, but I still want to try. Look, I would formally ask that the committee consider my substitute, the Democratic substitute. I agree with what Mr. McGovern is saying. But I also wanted to say this. You say you're frustrated. I'm just as frustrated, and I'll tell you why. First of all, because the Republicans spent 9 months trying to repeal the Affordable Care Act. Remember, look, community health centers, CHIP, are great, but they're basically supplemental to the Affordable Care Act. If that had been repealed, there would almost, I don't know what we would do with CHIP or community health centers. I mean, they would continue to exist, but they would be very hard-pressed to do much if they had repealed the ACA. from my sense of frustration is to come here and say, okay, we're in favor of a 5-year authorization. We're in favor of a 2-year for community health centers. But the way we want to pay for it is essentially by sabotaging, going after the Affordable Care Act and saying that, you know, as Ms. Slaughter said, what did she say? 688,000 would lose insurance because the grace period is shortened to 30 days. And I'm not going to get to the morality of whether people should pay or not on time, because a lot of times they just can't because they have, you know, food and other means. It's not a moral issue whether they're responsible enough, in my opinion. They don't have the money. And then when you talk about the prevention fund, what are we talking about here? We're eliminating these programs. These programs, he's suggesting that somehow they're going to exist. They'll exist in a much diminished capacity because that money is being used to pay for CHIP and community health centers. And so, you know, I don't even want to get, I'll get into the means testing again if you want to, but I mean, the bottom line is this is going to 100%, right? In other words, it's nice to say rich people are rich, sure. But now if you're now saying that 100% of the cost that you've got to pay for, one of the things I know about rich people is they find a way to use their money wisely. If they know they got pay 100% of the cost and they can find some other policy, catastrophic or other policy in lieu of that, they'll go for it instead of paying 100% of the cost of Medicare. And then that money doesn't go in to help pay for Medicare. So again, you're losing money for another health program.
And again, I think, you know, and I agree with you. You know, we have different philosophies in this Congress and different approaches to dealing with issues, and that's all fine and good, and we got to argue them out on the floor and
let me just say one more process thing, if I could. I don't want to be too bad, but you have to understand, my chairman is suggesting that somehow these things were delayed because Democrats asked for it. Bottom line is that they spent 9 months trying to repeal the Affordable Care Act, right? And the deadline came very close to the deadline when the CHIP reauthorization was going to run out. Then in the last few weeks, they come back and let's work on this. Well, it's almost the deadline now. And it's not because he, you know, loves me that he's saying, let's delay this. It's because he knows that if we don't come to a bipartisan agreement, it'll never move. So the fact that we don't come to a bipartisan agreement, we delay, is actually a good thing, because if we can come to an agreement, we'll actually get the bill done. Now the bill isn't going to get done.
I agree with you. I guess my only point here in this committee, because we're not the Energy and Commerce Committee, although we're acting like it today, we are the Rules Committee. And we are to set the terms of the debate. And the way it looks, because I think the fix is in, because the system is rigged here on this measure, is that even your substitute, Mr. Chairman, members will not have an opportunity to vote separately up or down on. It'll be self-executed. And I'm saying you have the ability to do that. You guys are in the majority. I'm just telling you, this is a bad way to do business. And you can beat us on, I bet, most of these amendments, but by not allowing them to come to the floor, I think it sets a process that is too convenient for whoever's in power. I just think it's a bad way to do business. I yield back my time.
Thank you very much. I'm going to try and defend myself slightly.
Okay.
Slightly.
You don't need to, but if you want to, you can.
Okay. Well, I'm going to choose to. Okay. 863 total amendments have been made in order during the year. 403 Democratic amendments and 340 Republican amendments and 120 bipartisan amendments.
And over 1,300 amendments have been blocked.
And I don't argue that point. All I'm saying is it's not an all or nothing. And I do encourage people to come up here, and we treat them fairly, and I believe that we try and do our best, and I admit that every single one of these members that are up here are thoughtful and articulate and get a chance to push ideas, and I appreciate you very much. The gentleman from Georgia. Gentleman from Georgia does not seek time. Judge?
Mr. Chairman, I always raise the question about members of the committee having their amendments made in order, and I don't have such a good track record on that. I don't have the numbers, but I assure you, many is the time that I've offered an amendment and it wasn't made in order, which causes me concern for all of us on this committee. I think we should have some measure of priority. Let me ask you, Mr. Walden, the $1 billion for Puerto Rico and the Virgin Islands, does it require matching?
As all states do, yes, sir. This is, and just if I could clarify, Mr. Hayes?
Please do.
Okay. We knew this year, and we already acted once, that Puerto Rico and the Virgin Islands, especially Puerto Rico because of their situation, would need additional funding, and we gave that. This is addition to that funding. It's about $1 billion for Puerto Rico and the Virgin Islands.
How do they access it if it requires matching and they don't have all the money?
So that's an issue that we are discussing about what to do on that piece of it. This we were working on before the hurricanes hit. So as I said in my opening statement, we recognize there are other Medicaid-related issues that may need to be addressed going forward. This just deals with what we knew we were going to have to deal with the Energy and Commerce Committee on their existing program. I recognize they may have an issue in trying to match this. We've not taken that issue up.
That's in substance what the real, yes, Mr. Palone.
I mean, look, I met after we had the committee markup with the head of the CDC, the Trump appointee, and she said that they don't have any money to pay for any match. So effectively, and I'm not saying that that my chairman is a bad guy. I'm just trying to say that the fact of the matter is it's fruitless. You have to give them 100%, otherwise they're not going to be able to get the Medicaid funding. Now, we have in the substitute $8 billion over the course of 5 years, which is what was the governor had asked for.
Which causes me to ask you, Mr. Palone, did you offer offsets in committee that would have paid for some of the things that we were talking about?
Both the Democratic substituting committee and the Democratic substitute that I'm asking you to consider today basically provides an offset by changing the day when we pay under Medicare Advantage and Part D. In other words, right now they get paid in advance by a month, and we would bring it up to the actual day when they have to pay out their claims.
Then back to you, Mr. Walden. Does offering up what I perceive as partisan offsets allow for the funding to be delayed? Is that likely to occur?
Well, I'm not sure I'd call Mr. Palone's offset a partisan offset necessarily, although it
I'm talking about yours.
Because it would violate PAYGO.
Your amended.
So actually, just to clarify, I'll try not to put words in your mouth, but I think some of we have multiple offsets. I believe we were close, if not in agreement, on a couple of them, but it wasn't enough to, and then we kind of went our own ways. Especially on the one for people making couples, $875,000.
So then answer my question, if you will. Will it cause delays?
We also believe, and we're told, that it would cause a PAYGO violation in the House, so we did not think it would withstand that rule, and so therefore was not fully viable. So we were trying to stick with something we could pass through all the wickets on.
I hear you. So then the notion of taking money out of one program to put it in another program, what happens to cost? For example, when you take money out of prevention, do you foresee that in the future that there's going to be an acceleration in cost?
So that's a really good question. So the way the prevention fund works is $2 billion every year by law goes into it. Then it's up to either us or my friends on the Appropriations Committee, and if both of us fail to do it, the Secretary of Health and Human Services, to decide which programs get funded. So it's not as if these programs every year rely on this funding. It can change every year. It's a pot of money that can be used for prevention and wellness, which we believe children's health insurance, health centers, diabetes for Indians, all of that qualifies as an appropriate expenditure from that fund, sir.
I hear you twice now, 3 times, really speak of the $2 billion.
Correct.
But am I correct that you're taking over a period of time, $10 billion out of prevention?
I understand why you think that, because that was the one we filed initially, but we have now receded to what the committee's work was, and it is $6.3 billion. That still leaves...
over a period of how many years?
10 years.
10 years.
So remember, so that's 6.3 out of 10 years. Every year you get $2 billion into the fund. For $20 billion, we're taking 6.3 to apply to these very important programs at
so
8.4 million.
Reduce revenue.
But Mr. Hastings, if I could ask...
Let me ask
sure.
him, and then I'll turn to you, Mr.
Yeah, no, I mean, this is money that is otherwise unallocated right now. It is not spent. It is simply, think of it as your checking account, sir, would have $2 billion every year put into it. It's up to you to decide how to spend it.
Yeah.
We're the authorizing committees. Majority of our committee, albeit all Republicans, said we think children's health insurance, we think community health centers should use that money, which is not otherwise allocated for 2019 and beyond.
And then most of us see that as poison pills, and that's why you don't have the bipartisan effort. What were you going to say, Mr. Colon?
Well, I'm not sure he's saying this, but I think the impression is being given that somehow this money is not going to be used for other things. I mean, the fact of the matter is that right now, the CDC budget depends on this prevention money for opioid prevention, vaccines for kids, lead poisoning, diabetes, heart disease, stroke prevention, youth suicides. Those programs will not be funded or will not be funded at the same level because you're now paying for CHIP or for community health centers. And I think what my chairman is saying is that he thinks paying for the community health centers or paying for CHIP are more important. But the fact of the matter is right now we're doing both. Yeah. So if you cut back, if you use one to pay for the other, you're not going to have those prevention programs in place. And as you, I think, are suggesting, Mr. Hastings, that will, in the long run, cost us more money because more people get dependent on opiates. They won't get treatment. And the same thing with the grace period. People that don't have insurance because they haven't paid their premium on time, then they're going to go to the emergency room and you're going to have to pay for them. So, look, the whole point of the ACA, prevention fund, grace period, everything, insuring people, was to make sure that people got care up front, saw the doctor, didn't end up in the emergency room. You were undermining that by cutting out or reducing these programs. That's the reality.
Yeah. The final question that I have, then, Mr. Walden, is when you changed the grace period, not you, but when your colleagues changed the grace period for missing a payment of premiums from 90 days to 30 days. According to CBO, this would kick some number of individuals off their health coverage. Do you agree with that, regardless of how many? CBO says it's 400,000. And so would this cause us to put people in jeopardy of their health coverage?
Well, I would just say this, Mr. Hastings, that anybody who doesn't pay their health insurance premium or their car insurance premium or their life insurance premium or any other insurance premium probably is going to lose what they're not paying for. Mm-hmm. And I don't understand why this is different, because to not do this means you're simply shifting that higher cost onto those who do pay. Because if you've got a group of people who skip their payments and the law says that's okay because we'll let you go for 3 months and you get 12 months worth of coverage for the price of 9, which is what happens today. And the Kinsey report I referenced said 90% of those individuals repurchase their plan the next year. We're just tightening it down to say you need to pay for what you're buying. Well, we have a lot of subsidies in place to deal with that, including the tax subsidies.
Well, quite frankly, I don't think that many people are gaming the system the way you put it.
Then it won't affect that many people overall, will it?
Yeah, well, then we'll see ultimately how that plays out. But I won't spend more time. In the interest of time, we have votes. But you did say to me that I should be nicer today. You and Dr. Burgess. Dr. Burgess has a new intern with him, and I want his new intern to know.
New staff person, he does.
New staff person. Then I would urge that person to escape now and don't come back up here, because I'm not going to be nice all the time. All
You're
right.
a good man.
Thank you.
Thank you.
I yield back.
You know, in honor of 25 years, you ought to be nice.
Every once in a while.
Today'd be a good day. Judge, thank you very much.
Colleague that's leaving, and he and I have an understanding as to why people ultimately leave this joint. We ain't doing nothing. You know?
Well, I will tell you, the gentleman from Tennessee is more than a volunteer. He's a great friend, and he's been here also a couple hours. So, yeah, could be. Well, and I apologize for that, but we're delighted that the young congressman's here. The gentleman from Washington.
Mr. Chairman, thank you. I don't really have a lot of questions, but I just wanted to let both Mr. Walden and Mr. Pallone know that how much people in my district appreciate the hard work that you and your committee have been putting in on this. These community health centers, I've heard from, I think, all of them in my district. They're critical. They provide vital services. I think you were, Mr. Walden, talking about the numbers of people that they serve and how many centers you have in your district. I couldn't believe it. It almost is a mirror image of my district in Central Washington. We've got 59 different sites serving almost 300,000 patients with an investment from the federal government of almost $40 million, which is almost exactly what you said. You know, we've got I think you might have the Farm Workers Clinic. We've got that. We've got the Yakima Neighborhood Health Services. We've got the Moses Lake Community Health Center, the Columbia Basin Health Center, Tri-Cities Community Health. I'm sure that's reflected in many districts around the country, and all of us know how important it is, especially for rural districts. You know, my largest community, my largest city, is less than 100,000 people. So we are, by definition, 85. Yours is 85. See, we're very much reflected in. We may root for different football teams on Saturday, but there's a lot of similarities. And then when you talk about the teaching health centers and the important work that is done in these education programs to attract and keep physicians in rural areas is so critical. That's one of the new doctors are attracted, like a lot of young people, they want to go to the bright lights of the big city, apparently. And so anything that we can do to enhance the keeping of physicians, caregivers to stay in rural areas is vitally important. This is a distinction that I wanted to share. My district is only one of 3 districts in the country that has more than 2 teaching health centers. We've got 3. And vitally important to reauthorize these crucial programs. And I just wanted to underscore the importance of the work you're doing. We may not agree on all the nuts and bolts of how to get this done, but I think we agree on how important it is to actually get it done. And wanted to express my appreciation to the hard work you put in.
I appreciate that, and I really do, and our districts are very similar. Mine's 69,341 square miles, would stretch from the Atlantic to Ohio. It's big out there, so 63 different sites. If I could clarify the record on one thing, though. Our first hearing to take up this matter was scheduled for June 14th, in the morning of June 14th. We obviously had to cancel that because of the shooting that took place. And so we tried to get on this immediately after we finished some other work we did in the House. We knew the importance of this and wanted to get ahead of it. Obviously, and you know, we had to cancel that day because that's the day Steve Scalise got shot and all of that. And then we rescheduled thereafter to go to work on this when appropriate. So, look, I think we all agree, Republicans, Democrats, these are really important programs to get done. I don't think there's a disagreement in terms of the lengths of extension, at least not huge differences. The real difference is how we pay for it. And I respect that we have difference of opinion here. I don't think we're that far apart. That's why we kept delaying to see if we couldn't come together, and we just frankly couldn't. And We know states are going to run out of money pretty quickly. They're pounding on our doors, as they should. We need to get our job done, and we know we're going to need time in the Senate to get things done. And so that's where we decided we just needed to move.
I agree. Time is of the essence. That's been communicated to me by the folks in my district. I get that, and again, just thank you both for giving us a very informative hearing and moving a very important issue forward. So thank you. Thank you, Mr. Chairman.
Thank you very much. The gentleman from Colorado does not seek time. Gentlemen, thank you very much. I think
Thank you,
were
Mr.
clear.
Chairman.
I will be quite blunt. I think you both provided expert analysis of not only your position, but of your ideas. Mr. Plum, we're delighted that you did take time. Chairman Walden, thank you very much. Most important and instructive, thank you very much. We're now on a vote, and so I would assume y'all would both want to make that. If you'll please remember, we have an awesome stenographer here who would appreciate anything you brought in writing in order to finalize the record. Thank you very much. Okay, we're ready for the next panel. I know that we've got two members. The gentleman from Tennessee, Mr. Duncan's been here for several hours. The gentlewoman, Jennifer Gonzalez-Colon, would also be available. If there's any other members in this that I'm not seeing, I would appreciate them coming forth on this panel. Mr. Duncan, we're delighted that you're here. You've been here a couple hours. We're delighted that you've done this. For both of you, please know that anything you brought in writing we appreciate you leaving for our stenographers, and it gives them help. Mr. Duncan, you're recognized. Yes, sir. Excuse me just a moment, please. Excuse me just a moment, please. Is it turned on? The clerk, Ms. Booth, if you'll make sure that that's...
Okay.
We do have trouble there, and I'm sorry. If I could ask you to please start over, I'd appreciate it.
I've got something that we just came up with today. I think we maybe could have gotten included in the regular bill, but I have a wonderful organization in my district called Remote Area Medical that has provided hundreds of millions of dollars of free medical care to people ever since it was founded 32 years ago, and they've provided free medical care for over 30,000 just this year. It's been featured on 60 Minutes and in 2 front-page stories in the Washington Post just in the last few months. They want to obviously do as much as they can, and they want to do more. And I have an amendment that would allow this group and other nonprofits that are similar to use health centers, community health center facilities and grounds to provide additional free health care that the health centers did not have enough time, resources, or staff to provide. And what this does, the amendment is written by alleged counsel, permits medical professionals with out-of-state active unencumbered licenses to use the health centers, grounds, and facilities in order to volunteer their services as within the scope of their practices on behalf of a nonprofit organization without any compensation for periods not to exceed 7 consecutive days if the state involved is notified of such permission. This group ordinarily comes in for 2 or 3 days and has 1,000 to 2,000 people. They did a free health clinic in Los Angeles a few years ago that had over 6,000 people that got free medical care. And they get doctors and dentists and nurses from all over the entire country to come in, usually to remote areas of poverty, and give all these people free medical care. And what this amendment would do would allow that volunteer service to be expanded if the secretary could even award grants to community centers to allow them or to help them set up one of these free medical clinics at over a weekend when ordinarily maybe they wouldn't be operating. And so that's what this amendment does. It's I think it's an amendment that most people would have agreed to, and I think maybe we could have gotten it in the base bill if we had started a little bit earlier. So, but since we didn't, we've come here with an amendment. We were told earlier that this might not be a closed rule, and so that's what this amendment is about, Mr. Chairman. So,
amazing. Thank you very much.
Thank you.
Jennifer, thank you for taking time to be here. We are not only aware of the circumstance that you and Stacy deal with, but our best wishes have been with you as we watched day after day through a series of hurricanes, perhaps as many as 3. I know 2 major ones came by you. We're delighted that you're here and the gentlewoman's recognized.
Thank you, Mr. Chairman. First of all, I want to thank you, Chairman Sessions, for this opportunity to actually speak in this committee in support of H.R. 3922. I also want to thank Chairman Walden and Chairman Burgess for all their leadership putting forward this bill together and hearing all over months after months about the pleas for Puerto Rican Medicaid funding. And I urge all my colleagues in the Energy and Commerce Committee for including $1 billion allocation to temporarily address Puerto Rico's impending Medicaid cliff and to provide for another year of the disproportionate share hospital relief. When we arrived here in January, over 1 million residents of Puerto Rico were facing the real possibility of losing their health care coverage due to the funding shortfall resulting from ACA and the disparate application that it does to the territories and for Puerto Rico. This Congress moved expeditiously to address this problem, allocating $295.9 million for Medicaid funds in Puerto Rico during the spring's omnibus. But this bill will allocate an additional $1 billion to Medicaid funding in Puerto Rico, and this is an important step in this Congress tackling this problem, giving us additional time, additional breathing room to actually find a permanent solution to Puerto Rico's and the rest of the territory's long-standing Medicaid inequalities. I, of course, would encourage our members to support and pass this kind of legislation. I mean, 3.4 million American citizens that are living on the island. This is one of the main issues. We don't even got money to the Medicaid program from April from the next year to September of the next year. So that's the reason we need this $1 billion. If we don't receive this $1 billion, we will have more than 1 million lives without health insurance coverage. And that's point blank the main issue here. When you can compare the per month cost of the Medicaid in the island is $168 per month. When you compare that nationwide, it's $660 per month. Even when you got a different population in Medicaid in Puerto Rico, we got 3.4 million, but 1 million of them are in Medicaid. We are not receiving the same amount of the rest of the state. And we know already that the committee and the chairmen of those committees are working together to have a permanent solution. And we are grateful for that. So this $1 million that is already being allocated here, it is a great opportunity and actually will move forward from the next year. Our main challenge right now, that is we don't have even the money for make the contracts for the providers for the next year. So I will keep my statement short, so if you may want to have any questions, I will be more than eager. But thank you again, and on behalf, I know Stacy Plaskett from the Virgin Islands, I was texting with her, and of the people of Puerto Rico, we're really grateful for having this money being allocated.
Well, I'd first like to quickly associate myself with the chairman's remark. I want to thank the gentlelady for coming and for the incredible job she's done on behalf of the people of Puerto Rico. Of course, we've had numerous areas that have suffered terrible disasters, but none worse than Puerto Rico, none, frankly, comparable to Puerto Rico. So I think Congress, on a bipartisan basis, wants to be helpful here, wants to make sure that our fellow Americans are given the support that they clearly need and quite clearly deserve. And I appreciate the gentlelady's role in making sure that that happens. And I think she'll, again, find a great deal of bipartisan support. My friend, Mr. Duncan, I think the chairman is off someplace trying to figure out some way to help you right now. So I'm going to refrain from remarking until he returns, but it's a good idea, and I appreciate you bringing it before the committee. With that, we go to the junk. Yeah, well, we normally would, but.
Thank you, Mr. Chairman. And Mr. Duncan, I'll just say, I don't know. I mean, your request is a good one. I don't know what the liability issues would be surrounding opening up a federally qualified health center to non-center providers to provide care. So I just don't know the answer to that. Normally, in the course of business, the Federal Tort Claims Act covers doctors and nurse practitioners in the federally qualified health center. So I think there would need to be clarification of that. I would just suggest to you, there's a senator that is the chairman of a major health committee, and you may know him. I don't know Senator Alexander. So I would make sure that the senator and his staff is fully apprised of your very good idea.
I was his campaign chairman the last time he got reelected. He's a long time friend. But I will say that this legislation in a different form, very similar, but not this exact amendment, but very similar, has been endorsed by the Federation of State Medical Boards, the National Council of State Boards of Nursing, the National Rural Health Association, and various other groups that are very similar. And I think it's something that we could work out, I hope.
And I would just encourage the gentleman, if this does not work out, to work with your senator, because it does sound like a good idea if we can solve the liability issues. Thank you, Mr. Chairman. I'll yield back.
You want to do that right now? Okay. Gentlelady from New York, ranking members recognized.
Yes, I'm pleased to support both of these, but Jimmy, one thing I need to understand, I appreciate how much that health care means in Appalachia. We've known that for years. Right. But are they going to use the facilities of the community health center, and will that be a permanent thing that they will do, or just when they're in the community?
No, they would just be allowed only during the time that they come in and do these clinics, the 2 or 3 days when they come in and do these
usually over
things.
weekends.
And it's amazing how many people turn out, and it's just there's such an overwhelming need, and so I think that we can work out any problems. Plus, it would give it would allow the secretary to give them some grants for these clinics if that would be appropriate. Also,
I sure would like to be helpful. Thank you both.
Gentleman from Georgia. Gentleman from Massachusetts.
Yeah, I don't think they're going to make any Democratic amendments to substitutes in order, but I'm certainly would support making a Republican amendment in order, so I hope they maybe will do that for you. But anyway, I support making your amendment in order.
Thank you.
Gentleman from Washington. Gentleman from Florida.
Mr. Chairman, I support my friend's amendment and urge that it be made in order. And I would say to Ms. Gonzalez Colon, if you heard my exchange with Mr. Walden, I would urge when you come back that you file an amendment that would correct that matching problem. I think he hears us, but at the very same time, it is still a part of this, and you do have that prerogative. So you should come up here with an amendment that would knock that matching business out, and I support it. As you would expect, coming from South Florida. Thank you, Mr. Chairman.
Thank you, Mr. Hastings. And we are working with the chairman of the subcommittee, Mr. Burgess, and with Chairman Walden. I know also the urgency of this bill to be approved, but we're working in the long-term solution, and that's actually that amendment you're talking about, the FMAP, the federal medical assistant percentage that is so important.
I know you're new, my friend, but catch these trains when they're moving.
I know,
okay.
I know, and we're working together on that, and actually Chairman Burgess was in the island actually looking at the hospitals to see that, and the disproportionate share hospital. And there are many other things. The low-income subsidy. We're talking about Medicare Part D, the drugs part, that we are not allowed to that, but it's going to be part of the mayor bill, and it needs to be separate from this one. So thank you, Mr. Chairman.
Thank you very much. Judge Hastings yields back his time, but Judge Hastings is actually trying to be very beneficial to a new young member, and I thought it was most generous of him to approach the issue. Thank you very much. Is there any other member that seeks time? Any other member that seeks time? I want to thank both of you. I need to look you directly in the eye and tell you for sure, Mr. Duncan, that what you've done has caused me to think a lot, and where I'm going to have to address the issue in about 35 seconds. But I want you to know that despite that, just like what Jennifer's issue was, it does not mean it's not alive, and it does not mean it's not a good idea, and it does not mean that I think that the time you spent here today was well worth not only the time of the committee, but the idea is most generous, and I've got to find a way to deal with it, and we're going to try our best. Thank you very much. Okay, is there any other member that would seek to come give testimony to the Rules Committee HR 3922? Seeing none, yes, ma'am.
If I could ask a point of personal privilege.
Yes, ma'am.
Because one of my staff members over here I want to recognize Georgia Gurkas. George has been here working with us for 9.5 years. This is his last Rules Committee hearing. He's from Scranton, Pennsylvania. His father was a dentist, and I understand that they assumed he would be one too. But he came to the Rules Committee as an intern and has practically been here ever since, making a career here, and we're grateful that he did, and we wish him well in his new endeavor. And I'll tell you, there's just nothing true to the rumors that he's leaving because he thought he would never see an open rule. He just simply got an offer that he couldn't refuse. So we wish George the best of everything. Thank
you. In fact, as you note, the professional advice, consent, hard work, and care that we receive from our associates is important, and we do appreciate it, and I'm proud of that. Proud of that. Okay. This now closes the hearing portion of HR 3922, and the chairman now be in receipt of a motion from the gentleman from Oklahoma.
Mr. Chairman, I move the committee grant H.R. 849, the Protecting Seniors Access to Medicare Act of 2017, a closed rule. The rule provides a 1-hour debate equally divided among and controlled by the chair and ranking minority member of the Committee on Energy and Commerce and the chair and ranking minority member of the Committee on Ways and Means. The rule waives all points of order against consideration of the bill. The rule provides that the amendments in the nature of a substitute recommended by the Committee on Ways and Means now printed in the bill shall be considered as adopted, and the bill as amended shall be considered as read. The rule waives all points of order against provisions in the bill as amended. Finally, the rule provides one motion to recommit with or without instructions.
Thank you very much. You've now heard the motion from the gentleman from Oklahoma. Is there amendment or discussion to that? Seeing none, we'll move on to the vote. Those in favor of the motion from the gentleman from Oklahoma, vote aye. Aye. Those opposed, no.
No.
The ayes have it. The ayes have it.
We better have a roll call, I think.
A gentlewoman would ask for a roll call vote.
Mr. Cole.
Aye.
Mr. Cole, aye. Mr. Woodall. Aye. Mr. Woodall, aye. Mr. Burgess. Mr. Burgess, aye. Mr. Collins. Yes. Mr. Collins, aye. Mr. Byrne. Mr. Newhouse. Aye. Mr. Newhouse, aye. Mr. Buck. Aye. Mr. Buck, aye. Ms. Cheney. Ms. Slaughter.
No.
Ms. Slaughter, no. Mr. McGovern. No. Mr. McGovern, no. Mr. Hastings. Mr. Hastings, no. Mr. Polis. Mr. Chairman.
Aye.
Mr. Chairman, aye.
The motion is agreed to. Clerk will report.
7 yeas, 3 nays.
Motion is agreed to. Accordingly, the gentleman, Dr. Burgess, will be handling this first rule.
And I have that pleasure for the minority.
And Mrs. Slaughter will be handling this for the minority. Chair will be in receipt of a motion, H.R. 3922.
Mr. Chairman, I move the committee grant H.R. 3922, the Community Health and Medical Professionals Improve Our Nation Act of 2017, a closed rule. The rule provides 1 hour debate equally divided and controlled by the chair and ranking minority member of the Committee on Energy and Commerce. The rule waives all points of order against consideration of the bill. The rule provides that the amendment printed in Part A of the Rules Committee report, modified by the amendment printed in Part B of the Rules Committee report, shall be considered as adopted, and the bill as amended shall be considered as read. The rule waives all points of order against provisions, and the bill is amended. Finally, the rule provides one motion to recommit with or without instruction.
You've now heard the motion from the gentleman from Oklahoma, H.R. 3922. Is there amendment or discussion?
Yes, sir, Mr. Chairman.
Gentlewoman is recognized.
Mr. Chairman, I have an amendment to the rule. I move the committee make an order and give the necessary waivers for an amendment to H.R. 3922 by Representative Pallone, number 6, the Democratic substitute.
Thank you very much. Discussion?
I think it's very important that we hear both sides of this issue. It's pretty apparent that they both are looking for the very same end, two remarkable members of the House. And I think we should make Mr. Pallone in order as well so that we can hear, frankly, the Democrat side.
Okay, thank you very much.
And then let people choose the best.
Further discussion? Vote will now be on slaughter amendment. Those in favor signify by saying aye.
Aye.
Those opposed, no. No. Noes have it, noes have it.
Got to have a roll call.
Gentleman, that's a roll call vote. Clerk will poll the committee.
Mr. Cole? No. Mr. Cole, no. Mr. Woodall? No. Mr. Woodall, no. Mr. Burgess? Mr. Burgess, no. Mr. Collins? No. Mr. Collins, no. Mr. Byrne? Mr. Newhouse? Mr. Newhouse, no. Mr. Buck? No. Mr. Buck, no. Ms. Cheney? Ms. Slaughter?
Aye.
Ms. Slaughter, aye. Mr. McGovern? Aye. Mr. McGovern, aye. Mr. Hastings? Aye. Mr. Hastings, aye. Mr. Polis? Mr. Chairman?
No.
Mr. Chairman, no.
Clerk will report the total.
3 yeas, 7 nays.
The motion, the amendment is not agreed to. Further amendment or discussion? Seeing none, the vote will now be on the motion from the gentleman from Oklahoma. Those in favor signify by saying aye. Aye. Those opposed, no.
No.
The ayes have it. The ayes have it.
Roll call, please.
Gentlewoman, that's a roll call vote. Clerk will poll the committee.
Mr. Cole? Aye. Mr. Cole, aye. Mr. Woodall? Mr. Woodall, aye. Mr. Burgess? Mr. Burgess, aye. Mr. Collins? Aye. Mr. Collins, aye. Mr. Byrne? Mr. Newhouse? Aye. Mr. Newhouse, aye. Mr. Buck? Aye. Mr. Buck, aye. Ms. Cheney? Ms. Slaughter?
No.
Ms. Slaughter, no. Mr. McGovern? No. Mr. McGovern, no. Mr. Hastings? No. Mr. Hastings, no. Mr. Polis? Mr. Chairman?
Aye.
Mr. Chairman, aye.
Clerk will report the total.
We have 7 yeas, 3 nays.
The motion is agreed to. Accordingly, the gentleman, Dr. Mike Burgess, will be handling this for Republicans. And I would estimate
that would be me.
And Mrs. Slaughter will be handling this for Democrats. Thank you very much. We do not anticipate any other meetings. We are on a vote, and I appreciate the committee's attention and professional conduct today. Thank you very much. This ends the hearing. Go vote.